we'll go on to the main topic, CVS. Today, it's already 9 o'clock. We'll try to complete all the topic ASAP. Okay, what is this? This building? Anyone? This building? Any guess? Which building is this? Something is written here. This one. What is this? Yeah, not AIG. Asian Institute of Gastroenterology is AIG. Is Asian Heart Institute located in Mumbai. Okay. They are the pioneers of many robotic heart surgeries they are doing. And they have 99% of success rate in this Asian Heart Institute. Okay. So so in this building we'll go and we'll see some CVS cases to better understand the CVS concepts. So let's start to see the basic CVS concepts. First, what are the basic tests? In any CVS disorder, you must write these two tests: ECG, echo. Okay? ECG, echo. Findings will be different, but the test is names. Remember, ECG, echo. What is ECG? What is echo? Somebody told me they both are same. No, they are not same, Baba. ECG is different. Echo is different. What is ECG? And what is echo? ECG, echo. ECG means electrocardiography. Echocardiography. How they both are different? Anyone? Echo, ECG. ECG is 2D representation of electrical activities in the heart. Okay. 2D representation of electrical activities in the heart. The electrical activities in the heart can have atrial depolarization, P wave, ventricular depolarization, QRS complex, or joint repolarization, T wave, QRS. So this is ECG. Echocardiography means ultrasound, nothing but basically ultrasound. This is ultrasound of the heart. To be precise, it is precordium. Okay. Ultrasound of the precordium. This is echocardiography. So 2D echo, 2D Doppler, 2D echo, 3D Doppler. Basically ultrasonography. Ultrasound. You check the heart with the help of ultrasound probe. Okay. This is ECG echo. Basic. EQRST. ECG. Now, in echo we have so many types of echo. Normally you put the probe on the chest, but in some cases you can also put the probe in the esophagus, and such echo is known as TEE, transesophageal echo. Transesophageal echo. It is useful especially in cases to visualize infective endocarditis very deeply. Okay, so this is about TEE. TEE are the special types of echo. So another basic concept is about CPR. What is CPR? Cardiopulmonary resuscitation. Yes, cardiopulmonary resuscitation. Why do you want to resuscitate? Because they are not working. Matlab what? Lungs are not carrying out their oxygenation and heart is not beating. So you will do resuscitation. Resuscitate both of them. How will you resuscitate? This American Heart Association says you should do CAB. C stands for not circulation. Here C stands for chest compression. Okay, chest compression, airway breathing. Chest compression, airway breathing. Okay. So first you have to seek help. Call the emergency number, seek help. Then you tap on the shoulder of the patient. Try to wake them up. If the patient is not waking up, check for breathing, then immediately start CPR. These steps are important. They will give you an MCQ about these steps, the 5 steps of CPR. First, call for help. Call emergency number. Call for help. Okay. You need more people by your side. Tap and shout, check for breathing, then start doing CPR. How will you do CPR? Compressions. Airway, check for airway, then give breathing. Okay. 2 puffs of breathing. After every 30 compressions, After every 30 compressions, you give 2 breathings. 30:2 ratio. Every 30 compressions, give 2 breathing. This is about CPR. CPR. Okay. Now, moving on to the basic question, and it is very most repeated question. One of the most repeated question is hypertension. What is hypertension? Everybody know, yeah, sir, systolic BP more than 140/90 is hypertension. More than 140/90 hypertension. Yes, more than 140/90 hypertension. But you don't know the basic concept. In hypertension, what is happening? Consistently high force of blood against the walls of artery. Blood is hitting the walls of artery with consistently with high pressure. As a result, see what will happen. The artery wall will get damaged. Damage to the arterial wall. Okay, damage to the arterial wall. Because of this only we are seeing a lot of complications. Okay. What is hypertension? Hypertension is a condition in which there is consistently high force of blood against the wall of arteries. So how much is the force? Pressure we measure 140/90. Generally we say more than 140/90 in at least 2 occasions. In at least 2 separate occasions. Okay. Okay, in at least 2 separate occasions that they should have elevated BP. Why hypertension occurs? Why BP will be high? See, there are so many mechanisms, but broadly, hypertension is divided into 2 types. Primary hypertension, seen in most of the cases as secondary hypertension. Primary hypertension is there is nothing wrong with the body. There is no disease in the body, but hypertension occurred. So, why because we have some factors, genetic factors, environmental factors. Genetic factors are family history of agitation will be there. Like in such patients, before that I'll tell you, see, blood pressure is in the body is mainly regulated by two two factors. One of them is sympathetic nervous system and another is RAS. Okay, so sympathetic, if you stimulate sympathetic nervous system, BP will increase. If you stimulate RAS, BP will increase. Okay, what is RAS? RAS is renin angiotensin aldosterone system. Okay, everybody knows it. From JG cells, renin is released, which will convert this angiotensin 1. Then angiotensin 1 to 2 is converted by is. Then what they will do? They will release this angiotensin 2 is a potent vasoconstrictor. Vasoconstriction, it will do increase BP. Then it will stimulate aldosterone release. Aldosterone reabsorb salt and water. That will increase BP. Okay. Basically, when the RAS is stimulated, there will be increase in BP. RAS stimulated. Okay. So BP can be increased by giving sympathomimetics or RAS agonist. If you want to decrease BP, give sympatholytics and RAS inhibitors. Okay. So genetic factors in such people, due to some family history, they will be having overactivity of sympathetic nervous system. Abnormal RAS activation they will be having, and their kidneys will not excrete sodium, leading to what, sir? High sodium in the body. High sodium in the body is a sucker for water. So more sodium, more water, more pressure. Okay. So this is the genetic factors. So there are some environmental triggers of stress, sedentary lifestyles, obesity, smoking, heavy salt consumption. Already salt is there in the body. Sodium is not getting excreted. They will consume more salt, leading to this primary essential hypertension. So in essential hypertension, we don't know perfectly which factor. That's why we say unknown etiology. But these are the factors. Okay. Primary hypertension, very important, it is being asked. Primary hypertension. What is hypertension? Consistently high force of blood against the wall of the arteries. How much should be the pressure? More than 140/90 in 2 occasions. Okay, understood? Now, what are the secondary causes of hypertension? Secondary causes of hypertension means the pressure in the arteries is not due to increased blood, but due to some pathology in the artery. So the lumen is getting narrowed because something is getting deposited on the walls of the arteries. What could be the, sir? What is that known as stenosis? So stenosis can occur in renal artery. So we say renal artery stenosis. What will happen, sir, if renal artery stenosis occur? Due to some reason. Something might be there here. Due to some reason, some tumor or some atherosclerosis, something. Renal artery stenosis or some external compression might occur. Because of renal artery stenosis, kidneys will not get blood. Decrease the GFR. Decrease GFR immediately activate RAS. Khatam. Hypertension. Okay? This is the mechanism. In the same way, atherosclerosis. If there are atherosclerosis, then there will be problem in the blood supply and BP will be more. Atherosclerosis due to narrow lumen. There is vasoconstriction. Okay. There are some endocrine disorders like hyperaldosteronism, pheochromocytoma, where norepinephrine is. So these are the drugs. These are the conditions in which secondarily hypertension develop. Like due to this condition, hypertension develop. That's why it is secondary hypertension. Okay. Clear hypertension? What is hypertension? Okay. Idiopathogenesis is clear? Now, moving on to clinical presentation. See, hypertension, as such, the patient will not come to you telling you my BP is increased. They'll come to you with the complications of hypertension. Okay. That's why hypertension is known as silent killer. So silently, the blood pressure will be more. The blood will be hitting the walls of the artery with more pressure, more pressure, more pressure. If they hit the walls of the arteries of the brain, that's why patient will have headache. Walls of the arteries of the brain, patient will have headache. If they hit the wall of the arteries of inner ear, patient will have dizziness, retina, blurred vision. So these are the symptoms. Okay. Then why breathlessness, sir? Breathlessness is because of impaired pumping. Why impaired pumping? See what happens. What happens? This is the heart. Assume this is the heart. Take a left heart to be precise. From here, blood is being pumped out into great aorta. Okay. So this aorta, what is okay? This aorta, due to some reason, more force is acting on the walls of the aorta. So this force, there will be some back force also. Because of this back force, what will happen? The walls of the left ventricle will get enlarged. So this in chronic leads to something known as LVH, left ventricular hypertrophy. So due to left ventricular hypertrophy, more blood will not be passed, leading to back pressure in the lungs, leading to breathlessness. Okay? Breathlessness. You know how breathlessness, why breathlessness will develop? Fatigue, not oxygenating, angina, if it occurs, the coronary arteries are blocked, angina will also be seen. These are the symptoms of hypertension. Every symptom, why it is occurring? Signs, elevated BP, which you can see already, signs of underlying disease like coarctation may, radiofemoral delay will be there. If there is renal artery stenosis, you will hear some auscultatory sound on abdomen, okay, especially lumbar area. LVH, what are the signs of LVH? So normally, if this is umbilicus, the heart, if the sternum is this sternum, the heart should be, the apex of the heart should be at the left fifth intercostal space in the mid clavicular line. Okay, half an inch medial to mid clavicular line. If left ventricular hypertrophy is there, then this apex will shift laterally. So there will be displacement in the apex. But apex will shift. Shifting of apex occurs. So this is, this you can appreciate it by doing inspection or palpation. And fundoscopy can be done to check for retinal blood vessels. Papillary edema can be noted. So this is about the clinical presentation of hypertension. Remember, hypertension, why headache occurs? Because of constant hitting. Okay. The blood is being like hitting the walls of the artery, cerebral blood. Okay, cerebral arteries. Now, investigation main BP measurement. So this is where you fail. See, this is the correct method of BP measurement. This is the correct, not the correct method. Okay. This is not the correct method. BP should be measured twice and two separate occasions, not at the same occasion. Okay, you should ask. And you should make sure patient do not consume caffeine, smoking, or alcohol before this. While measurement, see, look at this. This is a very basic thing. The machine should be at the heart level. Okay, the machine should be at the heart level. Here, see, machine is below the heart level and patient is not comfortable. Here, machine is not there. So this is not how you measure. BP measurement should be done. So this is the proper technique. Use proper technique to measure BP. Then, well, after that, do you need any investigation? Yes, to evaluate end organ damage. What are the end organs that are damaged here? End organ damage. See, heart is damaged. In heart, LVH, heart failure can occur. MI can occur. In the aortic dissection, what is aortic dissection? Blood is hitting the aorta with high pressure. Aorta will rupture. Aorta weakness of aorta will rupture. That is dissection of aorta. Okay. Then we have CNS में stroke, hypertensive encephalopathy can occur. What is stroke? Stroke means cerebral arteries will rupture, leading to hemorrhage, or they get blocked, ischemia, damage to cerebral blood vessels. Encephalopathy, why? Because acute rise in BP, because edema. And then kidney problem. Why kidney problem, sir? Because forceful, hitting of renal arteries will make their walls very weak, leading to chronic kidney disease. Okay. And then hypertensive retinopathy. So how many organs are damaged here? 1, 2, 3, 4. So minimum 4 organ damage. End organ damage. We say end organ damage. So tell me, what are the end organs? We have from top to bottom. We have the brain, eyes, heart, and kidneys. Okay, so these are the end organ damages. So you do your investigation will focus only on this. You detect CBP, anemia, electrolytes for the heart, fasting blood sugar to know the comorbidity, like diabetes, to rule out diabetes, lipids, etc. Everything. Additional investigation in secondary hypertension, like renal ultrasound for renal artery stenosis, RFTs, pheochromocytomas, etc. And the sleep apnea, sleep study. This is what you will do for hypertension. Okay? For hypertension. How do you manage your hypertension? Give antihypertensive. Yes, you can give antihypertensive, but you are not a second year student. No. So you have to write this. Medical management, rewards, lifestyle modification, rewards. First, stress. Again, exercise. How much exercise? If 150 minutes per week. Weight loss, aim for less than 25 BMI. Limit alcohol, limit smoking, and diet. Diet should be no salt or less than 5 gram per day salt. Okay. Dash diet. What is dash diet? Dietary approaches to stop hypertension. Dash diet. In dash diet, what they'll give? Fruits, vegetables, low fat dairy products. Low fat dairy products. If even after doing lifestyle management modification, if the patient is not, BP is not subsiding, then you start them on antihypertensive drugs. Okay. Then only you start. Do not start at the first stage. So what will be your management? You do stepwise therapy. First start them on first monotherapy. If they are not responding, add a second agent. Okay. Even if they are not right, consider triple therapy. If the patient's BP is not controlled even with 3 drugs, then we say it is a case of resistant hypertension. Resistant hypertension. Okay. For resistant hypertension, always you should look for secondary causes. Secondary causes. What are the examples of antihypertensive drugs? Very important. It is being asked. Yeah, antihypertensive may you can excrete diuretics. By giving diuretics, you can lower the blood volume. Or ACE inhibitors, ARBs, they basically inhibit RAS. Okay, they basically inhibit RAS. Beta blockers, they will inhibit what? Beta blockers, sympathetic blockers, sympatholytics they are. Calcium channel blockers, again, same. Aldosterone falls under, aldosterone antagonist falls under RAS inhibitors. Best examples, spironolactone, beta blockers, metoprolol, you can give all this. Initially, always safe. It is safe to start with ACE inhibitors. Because what? Because ACE inhibitors or ARBs, they have been shown to positively affect the cardiac remodeling. Meaning, if the individual was, due to hypertension, if the individual had developed some heart-related conditions like LVH or was going to develop heart failure, then these ACE inhibitors or these ARBs, what they will do? They will reverse these complications. They will make the heart normal. Okay, that's why they will, we always start with either telmisartan or this ACE inhibitors or ARBs. Monotherapy should be started with that. Then if it is not getting control, add some calcium channel blocker, ditherapy, then triple therapy. This is how you manage hypertension. Clear hypertension? Hypertension is clear, no? Oh, it's 9:21. Should we continue or should we stop? We can continue if you want. How many people? Like let's take a poll. Already 9:21. Is how many people should we continue? Uh, yes, please answer in the poll. Should we continue? You can answer the poll by this little icon is there in the activity. We'll go with the majority. For those who don't want, we'll continue this class tomorrow. Since tomorrow is a holiday, but we will continue this class. Cardiovascular system we have to complete. Yes, I need at least 1 hour more. How many of you are willing to stay? I'm sorry, but the psychiatric disorder needed time to tell you, because there was so confusing topic. Those topics were time taking. Okay, okay, the majority wants me to stop. Okay, thank you all. Thank you for attending. If there are any doubts for today's class, just text me. You can text me here or on the WhatsApp also. You'll be able to see. The whole point of this is to both, strengthen your concepts and also make you uh, exam ready. Okay. If you're not following, then it will be on my part. If you're not following, just let me know. Any part of my presentation till hypertension, any part, even psychiatry. Do you want me to repeat anything? Somebody is asking about MCQs. Yes, yes, MCQs of psychiatry will be put today. CVS will be put tomorrow. Any part of this presentation that you want me to repeat? Anyone? Any part you have any doubt? Anything? Any one line that you did not follow? You can participate. No issue. You are not being recorded. Okay, like your voice will not be recorded. We'll do editing later. Yeah, respiratory remaining part is being put. Yeah, it will be there shortly. By 25th you will get. Today is 23rd, no? By 25th you will get. Already over. You will get the recording. Anything else? Okay. I take this as a positive response. Can you tell me about? Yeah, somebody is asking about GIT quiz. Yes, GIT quiz already till group 6 already we have put out, but maybe you guys were missed. Zubair is asking about white coat hypertension versus masked hypertension. Okay. See, white coat hypertension means patient due to excessive anxiety, whenever they see the doctor, they will vary. Like in a clinical setting only, they will be hypertensive. So hypertension in a clinical setting is white coat hypertension. White coat hypertension means hypertension in a clinical setting. Outside they will be normal. Okay, normotensive. Okay. Then what is the other one? It was masked hypertension. See, masked hypertension means opposite of this. BP is normal in clinical setting. BP is normal because they'll be very calm. But in home, due to some some environmental stimuli or due to some work, they will be hypertensive. This is masked hypertension. Okay. Opposite of this. White coat hypertension means in clinical setting they'll be hypertensive. The problem is not the white coat hypertension. You have to focus on masked hypertension cases because they remain undiagnosed. So how will you do this? You ask them to do home monitoring of BP. Even if the BP comes normal in clinical setting, you ask them to go home monitoring of BP. Okay, Diksha wants me to revise hypertension. Okay, see, hypertension is nothing but the okay, elevation of BP elevation more than 140 by 90, everybody know. But what is happening in hypertension? In hypertension, the blood is pumping, with high force, the blood is hitting the walls of the blood vessels. So this is my blood vessel. I'll draw one blood vessel. See, this is my blood vessel. Okay. So the problem is, as soon as the blood gets ejected from the heart, it is getting ejected at high pressure and it is consistently hitting the walls of the artery. So due to chronic hitting, what will happen? The wall of the artery becomes weak. No. Okay. All wall of so all the complications or clinical presentations of hypertension will be because of this only. The basic concept is due to so much pressure, so much force, the blood is hitting the walls of the arteries. So first, if it hit, then initially there will be pain. So pain in different region is perceived as different things. So pain in the head is perceived as headache. Why? Because in cerebral blood vessels, blood is flowing at a high pressure. So headache. In inner ear, dizziness. In retinal vessels, blood vision. This is what is the main, basic concept. Why it occurs primary, secondary. Primary means we don't know the cause, definitive cause, but we can guess. So we can't write guesses. So we'll tell it is factors. So we say factors. Okay. So genetic factors, environmental factors. Genetic factors means familial history will be there. Meaning what? Like their family will be agitating. Okay. Genetic family history. So in such people, what we see is sympathetic overactivity. We see overactivity of sympathetic system or abnormal activation of RAS. RAS should be activated only when there is less blood flow to kidney. But if even if normal blood flow to the kidney, if RAS is getting activated, so those individuals we say primary hypertension. Primary hypertension means we don't know the etiology, but we are guessing. Okay. Secondary hypertension, due to some disease, hypertension develop. Disease could be of blood vessel or renal or endocrines, जैसे कि pheochromocytoma. Typical example, pheochromocytoma. Okay. Or some drugs like sympathomimetics drug. I told you, sympathetic nervous system, if it is stimulated, BP will increase. Okay. So the clinical presentations we talked about, investigations, routine investigations only we will do to rule out the end organ damage. What are the end organs that are damaged? The 5 end organs. What are they? Brain, eyes, heart, kidneys, and blood vessels. Okay, blood vessels. So blood vessel में aorta was there. Aorta can be dissection of aorta can occur. Okay, ठीक How will you manage? Lifestyle modification is rewards, mnemonic rewards. Antihypertensive drugs you can prescribe only if rewards is not working for this patient, or if the patient is having malignant hypertension, like severe hypertension disturbing its lifestyle activities, etc. So you start with stepwise management, monotherapy, add one more drug, not responding, consider triple therapy. If it is not responding, then this is a resistant hypertension case. If it is not responding to even 3 medications. So in such patients, you look for secondary causes that we already talked about, the secondary causes. Okay. So Diksha, you got it? Okay. Any other questions? Any part of this today's PPT you want me to repeat? No? Okay then. We'll end here. Thank you for attending, everyone. Class, crash course, medicine. Okay, what did we study till now? We have completed key concepts. Hypertension over. Till hypertension we studied, no? Study? Okay, okay, we'll start. So before we dive into some other topics, so after hypertension we have CHD. Okay, let me take this moment to tell you some basic concepts that will be very useful for you whenever you prepare. That will provide a solid foundation on which you can build on further knowledge. Okay, the solid foundation. Everybody, shall we start? Everyone join? Anybody who is not able to join? Okay, okay then. Okay, so let's start. See, heart is a very delicate structure. We all know pumping heart, very delicate structure. So, for the purpose of this discussion, I am drawing heart in the form of a box. Okay, just to simplify things. See, assume this box is a heart. Okay, so it has four chambers. So this is right atrium, right ventricle, left atrium, left ventricle. Okay, right atrium, right ventricle, left atrium, left ventricle. So right atrium receives the venous drainage from all parts of the body. Okay, the venous drainage. Basically, from the lower side, inferior vena cava, from the upper side of the body, superior vena cava. Okay, so inferior vena cava, superior vena cava. So right atrium receive venous drainage from the body, upper part. Total venous drainage is received by the right atrium. This will go into the right ventricle. Okay, when right atrium contracts. So through this valve, what is this valve? Anybody? The valve between the right atrium and right ventricle. What valve is this? Is it bicuspid, tricuspid? Anybody? Very good. Tricuspid valve. Okay. So it has three cusps. So it is a tricuspid valve. Tricuspid valve. Tricuspid valve. Okay. Now the blood goes into the right ventricle, and this from this right ventricle, the blood is pumped into the lungs. Okay. So we'll use this through pulmonary big blood vessels. So pulmonary aorta. The job of pulmonary aorta is to take blood from the right ventricle to lungs. So we have lungs here. Okay. So lungs full of oxygen. Oxygen. What they will do? They will oxygenate the blood. So they'll oxygenate the blood, and this oxygenated red blood is pumped back from the lungs by four sets of pulmonary veins to left atrium. From left atrium, the blood moves to left ventricle. Blood goes to left ventricle. Which valve? Mitral valve or bicuspid valve. Okay. So mitral valve is here. Mitral valve, bicuspid valve. From mitral valve, it goes into, through, it passes and it goes into left ventricle. From left ventricle, it is supplied to all parts of the body, total all parts of the body, by something known as aorta. Okay, the largest blood vessel. So this is a simplified overview. So human heart has dual circulation. So one has a pulmonary circulation. So right side of the body, right heart supplies pulmonary circulation. Okay? Whereas the left left heart is for the major systems. So systemic circulation. Okay. Left heart is systemic circulation. Right heart is pulmonary circulation. Everybody clear about this? Okay. Now let's go a little bit further and let's assume that my heart is failing. Okay. My heart is failing. Meaning what? Let's say my right heart is failing. So what should happen? Right heart failure. Meaning what? Right side of the heart is not contracting. So if right side of the heart is not contracting, meaning what? The blood, normally the blood will come, no? Normally, the blood normally from all the veins, superior vena cava, inferior vena cava, it will come directly into the right atrium. Now, right ventricle it will go. From right ventricle, we need some contraction, some systolic contraction to push the blood into the aorta, push the blood into the pulmonary aorta. But due to some pathology, my right side of the heart is not working. So right ventricle will not contract. If right ventricle will not contract, blood gets pooled, pooled in the right ventricle. Okay. Now what will happen? More blood keeps on coming, coming, coming. You know how much liter? 5 liters of blood. So it will keep on coming. Right ventricle. It will get accumulated. Now it will push, tricuspid valve and again the right atrial enlargement will occur. From right atrial, some back pressure it will go. Blood is unable to come now. Now inferior vena cava, the blood goes in the opposite direction in superior and inferior vena cava. What are you expecting to see now? You are expecting to see enlargement in superior vena cava, but superior vena cava is a little deeper structure. So you will see enlargement, distension, venous distension in the tributaries of superior vena cava, that is JVP. Okay, jugular venous pressure increases, that is jugular venous distension. The superior vena cava. What will you see in inferior vena cava? If inferior vena cava is a little bit deeper structure, so superiorly, what are their veins? So we have so many veins in the lower limb. So they will get distended, leading to lower limb edema. Okay. So edema, JVP, these are the signs of right heart failure. If right heart fails, we see these signs. Okay. These signs, edema, JVP, all those conditions. Okay. Right heart failure, main signs are this. Okay. Now let's assume we have left heart failure case. So left heart failure, what should happen? See, I'll draw, again, left heart here. This is left atrium. This is left ventricle. Okay. Now what was happening? From the lungs, the blood was coming via pulmonary veins. 4 sets of pulmonary veins draining into the left atrium from the lungs. Now, left ventricle, it passes through mitral valve, goes into the left ventricle. Now, our left heart is failed, meaning left ventricle is not contracting due to some pathology. We will see why left ventricle will not contract. We will see causes later. But concept. Okay, so left ventricle is not contracting. The blood gets pooled in the left ventricle. Blood gets pooled in the left ventricle. So it will push mitral valve will dysfunction, mitral valve will not contract, then it will go and fill the left atrium also. Now when the left atrium also gets filled, blood goes backward pressure into the pulmonary veins. So blood goes into the pulmonary veins and then what happens? Blood goes, pulmonary veins are connected to lungs. So blood go into the lungs. Okay, blood goes into the lungs. So this left heart failure will lead to pulmonary edema. Okay, left heart failure will lead to pulmonary edema. Now, if it is very severe, the blood might come out of the lungs, goes into the trachea, and comes out through mouth. What is this known as, sir? It is known as hemoptysis. Okay, hemoptysis. So everybody clear? Signs of left heart failure, right heart failure. Any doubts? Signs of left heart and right heart. We will go, into the further deep discussion, but just these are the basic concepts. In right heart failure, what are the main signs that you should see? We'll talk about auscultatory finding. Yes, we'll also talk about auscultation. Everything in detail. We'll talk about CVS today. but I want you to understand what is happening in right heart failure. There is back pressure. That back pressure is causing venous distension. In the upper part of the body, it is visible as JVP. In the lower part of the body, it is visible as edema. Left heart failure, the due to backward pressure, it is causing venous blood stasis in the lungs, leading to pulmonary edema, hemoptysis, etc. Okay, so these are the main findings. Okay, everyone understood? No, left heart, right heart, their functions. Okay. Yes, please raise your hands if you have understood. Okay, okay, okay. Chalo, chalo, we followed. Now let's talk about very, yeah, uh, what do we say? Cute, cute picture. This is about the CHD. Nilofer Hospital, we have a separate ward for this. CHD, congenital heart diseases. So what are congenital heart diseases? As you can see, there are two balloons here. So all congenital heart diseases are divided into two types, whether the baby is blue or pink. So pink baby, blue baby. Pink baby, blue baby. Okay. Pink baby means the heart disease is acyanotic. Okay. Blue means cyanotic. Acyanotic, cyanotic. So what are congenital heart diseases? They are some abnormalities present since birth. Okay. Congenital heart diseases are the abnormalities in the heart of the newborn present since birth. What is the types? Acyanotic and cyanotic. Acyanotic, cyanotic. Acyanotic means they do not interfere with oxygenation. Okay. So oxygenated blood, you know, there will be oxygen, considerable amount of oxygen in the blood. That's why the baby is not blue. In cyanotic, that oxygen, considerable amount of oxygen is not there. So that is cyanotic congenital heart diseases. Cyanotic congenital heart diseases can be remembered by this mnemonic. What are you saying here? Someone with the blue gloves. They are examining the teeth of a patient. So the mnemonic is 5 T's. The mnemonic for cyanotic congenital heart diseases. What are the 5 T's? The number one T is tetralogy of Fallot. Tetralogy, tricuspid atresia, right side only, right-sided heart. Tricuspid, right side, so right side heart. TGA, truncus arteriosus, TAPVC, these are all the T's. So 5 T's, cyanotic congenital heart disease. We'll dive into deep. Okay, just remember what is cyanotic heart disease. In cyanotic congenital heart disease, there is a problem with oxygenation. Meaning what? Pulmonary circulation is the problem. Pulmonary circulation, we talked about just now pulmonary and systemic. So pulmonary circulation is the problem. We don't have efficient pulmonary circulation leading to cyanotic congenital heart disease. In acyanotic congenital heart diseases, there is no problem in the pulmonary circulation, but there might be some problem afterwards. Okay, meaning what? There are some defects. There are some defects in the atrial septum or ventricular septum. Okay, due to that defect, this is the acyanotic congenital heart disease. Now, we'll dive into deep. We'll dive into deep. No need to worry. Just remember, pink baby, blue baby, acyanotic, cyanotic. What are acyanotic? All the defects, ventricular septal defect, atrial septal defects. Okay, the defects come under acyanotic. In cyanotic, the T's, tetralogy, tricuspid, TGA, truncus, arteriosus, and TAPVC. What is TAPVC? Total anomalous pulmonary venous circulation. Meaning what? What in TAPVC, pulmonary aorta arises from left ventricle. Okay, so that is an anomaly. That is TAPVC. Okay, okay. How many of you watched this movie? Anybody? Yes, raise your hands. You can raise your hand. Yes. Oh, very good movie. Okay, some things the Lord made. It's a very inspiring movie also, based on true story. So in this movie, they'll do a heart surgery for this case on the tetralogy of Fallot. So what is it? What is tetralogy of Fallot? Tetralogy of Fallot is a cyanotic congenital heart disease because it is a T, no? It begins with T. So it is a cyanotic congenital heart disease. What is happening here? Tetralogy, as the name implies, tetralogy. So we have 4 defects here. Those 4 defects, they combine and they produce the following symptoms. What are the 4 defects here? See, it all begins with, I will draw one diagram here. Our, our heart diagram. It has 4 chambers: right atrium, right ventricle; left atrium, left ventricle. Okay, so normally what should happen? From left ventricle, aorta should arise, and from right ventricle, pulmonary artery should arise. Okay, pulmonary artery should arise from right ventricle. We'll use this to denote pulmonary artery, and we'll use this to denote aorta. Okay, now it all begins with a defect in the ventricular septum. Okay, so there is a ventricular septal defect. There is an opening between the 2 ventricles. Ventricular septal defect. It all begins with this problem, ventricular septal defect. Because of this defect, what happens? The aorta, which was supposed to arise from the left ventricle, now it arises from the junction between left ventricle and right ventricle. Okay, aorta arise from here. It was supposed to arise only from left ventricle, from this point, but due to this ventricular septal defect, it gets pushed medially. So it arises from both left and right ventricle. This aorta is known as overriding aorta. Okay? Overriding aorta. Afterwards, what happened? Due to overriding of aorta, the pulmonary artery which was freely originating from here, now it gets compressed at this point. Pulmonary artery gets compressed at this point. It was freely originating from here. It was going like this. Okay. But due to aorta, overriding of aorta, origin of the pulmonary artery is compressed, leading to something known as pulmonary stenosis. Okay, pulmonary stenosis. Everybody, I'm trying to be as slow as possible. If you're not able to follow me, just you can put your doubts in the chat box. If you're not able to, it all begins with VSD. VSD will lead to overriding of aorta, meaning aorta arises from both left and right, the junction between both right and left ventricle. That will cause compression at the origin side of pulmonary artery, leading to pulmonary stenosis. Pulmonary stenosis. Because of pulmonary stenosis, what happens? Whenever the right ventricle contracts, the right ventricle is unable to push the blood through this narrowed pulmonary aorta. So there is always a back pressure. So this back pressure, blood comes and hit the ventricle wall again and again, again and again. This will cause what it will cause? The last tetralogy, RVH, right ventricular hypertrophy. Okay, so this is the tetralogy of Fallert. These are the 4 components. First, VSD, overriding aorta, pulmonary stenosis, RVH. Pulmonary stenosis, in some books, they also written this as a right ventricular outflow tract obstruction. The one and same only. Okay. Right ventricular outflow tract. What is right ventricular outflow tract? Pulmonary aorta. That is what we are talking about. Outflow tract obstruction means there is stenosis. Okay. So it's tough. Now, this is what TOF means. Okay. What did we study till now? What did we study? What is TOF? Okay, what is TOF? Everybody followed, no? What is TOF? Now, what does TOF include? These are things that TOF includes. Okay. Why TOF occurs? Why tetralogy of Fallert occurs? Yes, etiopathogenesis is what I'm interested in. See, TOF is associated with some abnormalities of chromosome 22. So chromosome 22, the abnormality, famous abnormality, Digiot syndrome. The Digiot syndrome, what happens? There is a abnormal cardiac development. So always, patients in children presenting with TOF always rule out Digiot syndrome. You do karyotyping and you look for a specific region. Long arm, the region 11.2. If it is deleted, it means Digiot syndrome is confirmed. Okay, so that is what. Okay, genetic factor is this one. Environmental factor during pregnancy, if the mother get diagnosed with diabetes or rubella, poor nutrition, or alcohol if she take during pregnancy, especially in the first trimester. First trimester taking alcohol, khatam. Welcome tetralogy of Fallot. Now, let's not go a little bit further. I'll only ask you, what is the main problem here in tetralogy of Fallot? Out of the four pallets, okay, out of the four defects that I talked about, which is the most severe according to you? Any guess? Any guess? You can type in the chat box. Yes, Khushi, Sudhakar, Akhil, Shivani. You can type in the chat box. Out of the four, which do you think is most severe? Yes, anyone? If you interact, then only you will understand CVS, because CVS is like very volatile. Yes, somebody told overriding aorta. Yes, Shivani told pulmonary stenosis. Yes, Zubair, Akhil, pulmonary aorta, overriding aorta. Yes. Any more guess? It's okay. You are not being recorded. Okay, we will edit and send it to you later. Okay, VSD. Somebody told VSD. Yogita. Yes. Any other RVH Eisenmenger? Okay. Yes. Okay. See, the main problem here is, yes, even though VSD was the cause of all this tetralogy, which led to a chain reaction forming these four defects. Okay, VSD was the cause, but the main problem is because of pulmonary stenosis, pulmonary stenosis, pulmonary stenosis. Because of pulmonary stenosis only, no RVH occurred. Okay, if pulmonary stenosis was not there, then right heart would have functioned normally. Okay, right heart would have functioned normally. There was oxygenation would have gone normally. Would have taken place normally. But because of this pulmonary stenosis only, we will see all the symptoms in this baby. Etiology of father baby, pulmonary stenosis. Okay, pulmonary stenosis. So what is happening? First, if there is, depending on the degree of stenosis, we will see if the stenosis is mild in stenosis, then such babies will be pink only. So it is known as pink tetralogy, pink tetralogy. But in most of the cases, what we find cyanosis, that too central cyanosis. Anybody who can tell me the difference between central and peripheral cyanosis? What is central cyanosis? What is peripheral cyanosis? Yes, physiology question. Cyanosis. Cyanosis means, no, bluish discoloration of only skin. Bluish discoloration of only skin and mucous membrane. Okay? It can be central, it can be peripheral. Central means the cause mostly cardiac cause or some other reason. But peripheral means there is a distribution, circulatory problem. Especially seen in extremities. If it occurs in the extremities, it is peripheral cyanosis. But here central cyanosis is seen, meaning what? Central part, lips, tongue, and skin. Okay? That is central cyanosis. That central, we will talk about hypoxic spells, okay? But first, remember, central cyanosis is there. Why central cyanosis is there? Anyone? Because the right heart is not functioning. Right heart is not functioning means what? There is no oxygenation. If no oxygenation means cyanosis. Okay, bluish discoloration. Cyanosis. So cyanosis, no oxygenation, no oxygen for any metabolism leading to FTT, failure to thrive. Even if the baby thrives, the baby poor growth because no cyanosis. Okay. Oh, okay. Even if the baby, becomes a child, as soon as the baby takes their first step, baby develop SOB. Because to walk also we need oxygen. Oxygen, muscle needs oxygen to contract. Okay. So in auscultation, what you will find which type of murmur. Okay. Uh, a little bit about murmurs. We can be right. See. Okay. Murmurs. What is a murmur? I thought I will tell about this in vascular disorders, but okay, let's do it now only. What is a murmur? Anybody? What is a murmur? The one which you hear with a stethoscope is a murmur. What is a murmur? Abnormal heart sound. Okay, very good. Abnormal heart sound. Okay, can or cannot be heard with a stethoscope. Abnormal heart sound. But what is abnormal heart sound? And why it is not normal? How do you define a normal? Murmurs. Always remember, use this word, and it is a way favorite question in Viva. What is a murmur? Turbulent blood flow. Okay. Murmurs always occur when there is a turbulent blood flow. So normally, if this is my blood vessel, blood will flow in the streamline normally. But if it encounters, some obstruction or something, for example, let's look at this blood vessel. Let's say we have some growth in the wall of this blood vessel, some plaque or something is there. So whenever the blood flows through this blood vessel, there here it will, obstruction, there is a path. So blood will form a turbulent path around this obstruction. And this turbulency in the blood flow creates a murmur. That sound. Okay. So murmur is based on, at what time it is occurring. If the murmur occurs when the heart contracts, so we say it is a systolic murmur. If the murmur occurs when the heart relaxes, so we say it is a diastolic murmur. Diastolic murmur. If the murmur occurs through the contraction and relaxation, then we say it is a continuous murmur. Continuous murmur, I know only one condition, and that is very important condition, patent ductus arteriosus. Systolic and diastolic we will read, okay, as we build on this. Everybody understood what is a murmur? When murmurs occur, turbulent blood flow. Okay, whenever the blood flow is turbulent. Now let's talk about here. See, here, whenever the right ventricle contracts, the right ventricle, due to a stenosed pulmonary artery, is unable to pump into the pulmonary artery. Aorta. Okay, pulmonary aorta. So during systolic phase, we will hear this murmur. So this is a systolic ejection murmur. Okay, systolic ejection murmur. On auscultation, we see systolic ejection murmur. Okay, and then if in severe cases, signs of right-sided heart failure, because it is right-sided pathology. Okay, right-sided heart, right-sided pathology, cyanotic congenital heart diseases. Everybody understood, no? The clinical presentation of TOF. Anybody not able to follow? You can type in the chat box. Okay, now, if you don't treat, what will happen? Hypoxic spells can occur. Spell matlab jadoo. Okay, some spell kar di. We'll talk about what is hypoxic spell, but see, hypoxic spells, then infective endocarditis, especially around the VSD, around this, the septal defect was there, no? In this case, between the ventricles, there was a septal defect. So this septal defect will act as a petri dish for the bacteremia. So that will cause infective endocarditis. We'll talk about this also. And that infective endocarditis, that that vegetations may dislodge, creating a septic emboli that might go into the brain. And due to chronic hypoxia, polycythemia can occur. That polycythemia will thicken the blood, leading to again stroke. This is another reason. Heart failure, we already talked about this, right heart failure. Some bleeding disorders and gout can also be seen in such patients. Okay, this is about TOF. So what is this hypoxic spell? Okay, in TOF, whenever the baby, normally babies cry, no? Whenever the baby cry, look at this picture. This is a hypoxic spell. So whenever the babies cry, baby will develop this cyanosis. They will become blue, dark blue they will become. No. Overriding aorta means right ventricle blood, yes, it can go, and from left ventricle also it can go. But the main thing here is in aorta also, there is mixture of oxygenated and deoxygenated blood. And pulmonary stenosis में there is further decrease in oxygenated blood. ठीक है, so there is blood is not getting oxygenated. Okay, overriding aorta means aorta originating from both right ventricle and left ventricle. Okay, yes, Zubair, I think your doubt is clear. What is hypoxic spell? Hypoxic spell means whenever the baby cries, baby becomes dark blue. Why it is known as hypoxic spell? Because it occurs due to hypoxia. They are also known as TET spell. These are the different terms in pediatrics. Favorite question of examiners. What is hypoxic spell? So what happens here is whenever the baby cries, the baby's intrathoracic pressure increases. So this increase in intrathoracic pressure will compress the pulmonary vasculature, which is already compressed. Pulmonary stenosis is there already. So this will further worsen the cyanosis. That's why the baby becomes more blue whenever they cry. Okay. Then another reason for this is whenever the baby cries, crying will decrease the systemic vascular resistance. Meaning what? The body thinks that baby is not getting enough blood. That's why the baby is crying. So to stop the baby from crying, the nervous system of the baby, what it will do? It will dilate the arteries in the peripheral region. Meaning what it will do? It will dilate the arteries. Meaning what? Meaning, see, there was this heart, right atrium, right ventricle, left atrium, left ventricle. Okay? So there was this VSD defect. Now, what did I tell? Crying will lead to decrease in systemic vascular resistance. Meaning what? The body tries to, vasodilate all the branches of this left heart. Meaning aorta further branches will get dilated. There is vasodilation. So here negative pressure is created. Meaning what? What is favored? Right to left shunting is favored. Meaning the blood which was there in the right ventricle further goes into the left ventricle. So the deoxygenated blood which was there in the right ventricle mixes with the oxygenated blood of the left ventricle. Further decrease in oxygen concentration of the blood happens here. This will deepens the cyanosis. I think everybody followed. Anybody? Okay, one of the reason is there is increase in intrathoracic pressure. The other reason is SVR decreases. What is SVR? Systemic vascular resistance decreases. Meaning all the main arteries will get dilated. Vasodilation occur. That will favor this shunting. And this shunting, because of this shunting, deoxygenated blood will be more. This will further worsen the cyanosis. Okay. Everybody followed? Okay. Yes. So there is no oxygen. SpO2 is very less. Syncope can occur. Okay. Syncope can occur. To decrease this, what you can do? Okay, this is about hypoxic spell. This is about TOF. What are we studying? Where are we? We are in congenital heart diseases. We are studying TOF. In TOF, 4 components we study. After that, we are studying about clinical presentations. In clinical presentation, we told it is central cyanosis. Because of this, no oxygen. Baby will not thrive. Even if the baby thrive, you have poor growth. Even if the baby becomes a child, while walking also the baby will have SOB. Auscultation में what you will find? Ejection systolic murmur. Okay. Chronic cases में signs of right heart failure. This is about the TET spell also we studied. Now how are you going to manage this baby? So if you take a chest X-ray of this baby, you will be able to find boot-shaped heart. Why boot-shaped heart, sir? Normally, what is boot-shaped here? See this part, this region. This region is enlarged because what is this? This is right ventricle. The base of the heart is formed by the right ventricle. Right ventricle is enlarged, leading to this enlargement of the heart is what is, the radiologists, they love to give different names. So for them, it appeared as a boot. So that's why it is a boot-shaped heart. Okay, so boot-shaped heart in chest X-ray. Echo is the gold standard for diagnosis. Echo. Why echo is gold standard? Because you can visualize all the components of TOF. ECG, yes, ECG you will be able to find RVH, etc. See, just remember these 3 things in any CVS case. You have to write these 3. Their findings might be varying. Okay, how are you going to manage? Management. Medical management, can we do medical management? Yes, we can do only for cyanotic spells, because top only surgical management is the indication. So what you can do for cyanotic spell? Why cyanotic spell occurred? Because of decrease in concentration, oxygen concentration. So you give oxygen, you supply the baby with IV fluids to increase the blood volume. You keep the baby in nichest position. So what happens if the baby is in nichest position? In nichest position, what was the reason? The crying was leading to vasodilation. No. So if the baby assume this position, basically what the baby is doing, it is baby is kinking the arteries. Okay, kinking the arteries. So basically the baby is causing vasoconstriction of the lower limb. That will increase his pressure. That will improve the cyanosis. Baby might become pink. Cyanosis will get resolved if the baby assume knee chest position. In olden days, they used to practice this. Now we have drugs. Since it is vasodilation, we are giving vasoconstrictors, beta blockers. Typical beta blockers can be used in cough. Okay. And prophylactic antibiotics can be given to decrease the incidence of infective endocarditis. Infective endocarditis. Okay. So we have corrected cyanotic spells. Now, next, what you can do? We can do the corrective surgery. So the total corrective surgery means all four components are corrected. So how will you correct VSD? For VSD, you close VSD. The defect is closed. You do patch closure. For right ventricular hypertrophy, what you can do? You will resect. Okay, resection can do. For overriding of aorta, repairing can be done. For pulmonary stenosis, you can relieve. How you can relieve? The stenosed, this for example, if this is a normal valve, then this will be the stenotic valve. Okay, stenotic valve. This will be stenotic valve, decreased lumen. So how can I correct this? Either I can resect the excess part to make it like this, or I can directly replace the valve. Okay, so this four steps is known as total corrective surgery. Total corrective surgery. When is the best time to do? When the baby is between 4 to 12 months. So depending on the severity, if it is very severe, do it at 4 months. If it is mild, do it at 12 months. Okay. So for example, if the baby is between 1 to 3 months, what you can give? Anybody? Just now I told ideal time of surgery is 4 to 12 months. Let's say baby is is a newborn only, less than 1 month. Less than 1 month baby presenting with severe symptoms, crying at a hypoxic spell is there, everything is there. What you can do for this baby? Can you do surgery? Okay, somebody is telling give medical management. Yes, medical management we can give, but for less than 1 month, if the symptoms recur a lot, what will be your management? What you can do? Yes, anyone? Dikshita, oxygen supply. Okay, so you'll admit the baby forever. So till 4 months, you admit the baby in the hospital, risking the baby for hospital acquired infections. They can give oxygen at home also, somebody said. Yes, they can give oxygen at home, but the baby will move. No, newborn baby will cry. That will further worsen the cyanosis. The newborn baby cannot assume the nichest position also. If somebody is telling give beta blockers, yes, we can give beta blockers, but how many times a day you can prescribe beta blockers for such baby? It is a problem, no? So for this only we have another palliative surgery. We said palliative surgery in which we create a shunt. So this BT shunt we say blood lock tossing BT shunt. So BT shunt basically what it is doing, it is very good. See, from the right ventricle there was pulmonary artery. Okay, there was pulmonary artery. So, but this pulmonary artery, what was the problem? There is a narrow. Okay, it had pulmonary stenosis. So this was right ventricle. From right ventricle, there is narrowing here, and that's why blood was not going from right atrium to right ventricle to pulmonary aorta. Okay. So, but again, the left side there was no problem. From left ventricle to aorta, blood was easily going. Okay. Now, now, what? One of the branch of aorta is a subclavian artery. Okay. So what did we do? We created a shunt between these two arteries. So blood gets filled in the left ventricle. It gets pumped out into the aorta. From the aorta, blood goes into the subclavian artery. From the subclavian artery, blood goes into the pulmonary system. Yeah, this is how you bypass this narrowed portion. This is how you save this baby. Okay, so everybody followed. It is basically a shunt. Okay. Okay. Any questions in TOF? Yes, Eisenmenger syndrome. Yes, it can occur in chronic cases of TOF, where they will not have cyanosis at all. The baby gets used to it, but it is not has not been asked in the exam. That's why we did not include it in crash course. Yes, if you want to dive deep into this topic, you can consider joining our this NEET mastery program, mid mastery program, where we talk about this the extra stuff. But for top, as far as PEDS and this medicine is concerned, these are the main questions. Okay. So will there be any edema in top as there is RVH? Yes, RVH is there in severe cases. We do find this right heart failure symptoms as we talked about here. Edema. See, we have written here about edema. Edema. Yes, liver enlargement edema can occur. Yes, Shivani. I hope I answered. Any more questions about TOF? No? Okay. Okay. We are moving on to the next topic. Infective endocarditis. So, almost everyone must have watched this series, Hojandi. Can anybody tell me the episode name? At least the season name. Yeah, someone said, yeah, it is season 8. Season 8. Yes, season 8, this girl, he will diagnose her as infective endocarditis. Okay. What is infective endocarditis? Infective, as the name implies, see, infective is infection. Endocarditis means endocardium of the heart is getting infected, leading to inflammation. Okay. Infective endocarditis. So why there is infection? Most commonly, the infection is because of these oral cavity lesions. These people have oral cavity lesions. So that oral cavity lesions, the dental lesions, that bacteria from that side, the dental caries, will go into the blood. Okay, first. So there are three predisposing conditions for infective endocarditis. The first condition is the bacteria should be present in the blood. And the second condition is there should be some underlying heart disease, meaning what? There should be some structural abnormality in the heart. So as we said in TOF, there was structural abnormality. No, there was this VSD was there. So there is a structural abnormality in the heart. So what will happen? These bacteria, they like to stick around. Okay. So they will stick around. They will stick to this valve. Bacteria, they'll stick to this VSD, and this, after this, what this will become as a petri dish for the bacteria. Whenever the immunity of the system becomes low, then only infective endocarditis symptoms occur. So what are the three conditions? Bacteria should be there in the blood, then there should be some underlying heart disease, and the patient should have decreased immunity, either due to HIV something or due to malnutrition. Okay. So these are the three predisposing factors and these are the three conditions. While solving MCQs, always see whether these three criteria, the three predisposing factors are there or not for the patient. Now, what type of bacteria? So if the infection occurs from oral cavity, the bacteria is Hasse group of bacteria, Haemophilus, Actinobacillus, Cardiobacterium, Eikenella, and Kingella. Okay, Hasse group of bacteria. If the infection is seen in IV drug abusers, we see right heart failure. Right heart, because IV drug means from venous side it will go into right heart only. No? So right heart infective endocarditis we see. Main culprit is staph. Okay. Remaining all we will see left heart wala. So left heart may if it is a prosthetic valve, that is after transplantation. after heart cardiac surgery, if it is a prosthetic valve, new valve, so the culprit is coagulase negative staph. Coagulase negative staph. If it is a previously damaged valve, strep is the culprit. Okay, so these are the causes. Main causes are strep and staph. If you don't remember also, but do write this in etiopathogenesis. The three conditions for infective endocarditis. Okay. Oh, also okay. So the conditions already explained. So in infective endocarditis, the main thing is this fever. Fever must be there. Fever with chills. Fever must be there. Then fatigue has to be. It is common in any heart disorder. Most importantly, new heart murmur is the criteria. New heart murmur. Meaning what, sir? Sir, what do you mean by new or changed heart murmur? Meaning, see, what did I tell you here? Underlying heart disease. So the patient already had a heart disease, and that heart disease has some murmur. Okay, it was some murmur was there with the patient because underlying heart disease was there. But on top of that, if that patient develop infective endocarditis, then there will be a changed heart murmur, new murmur or changed heart murmur. Okay. And this since it is a chronic inflammation, weight loss will be present, splenomegaly will be present, weakness in calculation. Okay. Finger presentation, everybody clear. Main thing is fever, new or changed heart murmur. New or changed heart murmur, weight loss. So what are the complications? Infective endocarditis, infection go haywire, haywire. So what can happen? I told this the VSD around the VSD the bacteria stick. Bacteria stick around VSD. Around VSD the bacteria stick. So this is basically a ring abscess. Ring abscess. Okay. So where the bacteria is sticking in the endocardium. In the endocardium. If the bacteria penetrate deeper and go into the myocardium, so this is a ring abscess can transform into a myocardial abscess. Okay. From myocardium, if it go into the pericardium, the outer side, it will cause pericarditis. So these are the complications: ring abscess, myocardial abscess, suppurative pericarditis, and then at last perforation of the heart, rupture of the heart can also occur. Okay. This is the cardiac complication. The valvular dysfunction, always remember valvular dysfunction, left is more than right. Left heart is more affected here. Left heart is more affected than the right side. Right heart is more mainly affected in IV drug abusers. Okay, IV drug abusers. Right heart. Okay. These are the complications. Cardiac complications in this. Now it also has some extra cardiac complications where that vegetation which was there, the vegetations might get dislodged. This was the VSD, for example, in the heart, it had some VSD. So this was some ring abscess was there here, some ring abscess. So if the blood flows from here to there, this ring abscess, some bacteria might dislodge, leading to septic emboli in various organs. Like, for example, the emboli is large, it can go in brain, spleen, kidney, and cause infarction. Meaning what? They will die. CVA, kidney, acute kidney injury, splenic infarction. But if the emboli are small, they will cause some subungual hemorrhages or non-tender Janeway lesions. So what are these Janeway lesions? See, Janeway lesions mean this, just non-tender lesions on the palms and soles. Janeway lesions, palms and soles. Palms and soles. Now, immunological phenomena is also occurring. Immunological phenomena, the body immune system is trying to fight off the infection. But infection is so severe or the immune response is so like mild immune response is there, body is unable to fight. So what will happen? The immune system will become irritated. That irritated immune system, even if we are irritated, what we'll do, we'll just start throwing things here and there. No? So same way, the irritated immune system will start damaging our own body parts. So if it damages the nephrons, glomerulonephritis, damaging the joint structure, arthritis, damaging especially the toes, on the toes we will find painful nodule. Ocular nodes are painful. Ocular nodes and in the retina also red rod spots. So these are the main complications of infective endocarditis. Okay, where are we? Let's recap. Where are we? We are in CVS. What are we studying? Infective endocarditis. What did we study in infective endocarditis? It is inflammation of endocardium of the heart. Why there is inflammation? Because of infection. What are the infections? Staph, strep. Main culprit in IV drug abuser is Staph aureus. In strep, prosthetic valve, okay, and oral cavity has a groove, okay. Three conditions: bacteremia, underlying heart disease, low immunity. Okay, in the picture we know complications we studied. How are you going to diagnose? Duke criteria, modified Duke criteria. Everybody know it has major criteria, minor criteria. Remember three major criteria, three major criteria. Among them is new valvular regurgitation. Okay, new valvular regurgitation or evidence of new disease on echo. On echo, evidence of new disease on echo. Positive blood culture, obviously major criteria. Minor criteria is fever, predisposing, those three predisposing conditions that we talked about, three wale. Embolic phenomena, immunological phenomena, microbiological evidence. So these are the minor criteria. This everybody will write, but you will forget this one. Like you diagnose infective endocarditis, at least two major criteria should be there, and one major, three minor. One major, three minor. Okay, don't write two minor. One major, three minor. Three. Why three, sir? How are we going to remember three? Because three conditions. Three conditions we talked about, the three predisposing factors. Three conditions. That's how you remember three. One major, three minor, or directly five minor criteria. Satisfied five minor criteria. Just remember this one. Do not remember passable IV. Nobody is asking. Definitive diagnosis can be made only with two major criteria, one major, three minor, or five minor. Okay. How are you going to treat this? Antibiotics you give because it is infection. Give anti-inflammatory. Infection may what are you going to do? You have to cover strep and staph. So step first, any type of staph you can give vancomycin and VG and gentamicin, VG combination. You can add VGR if you are suspecting some biofilms, okay, especially prosthetic valve. VGR, R for rifampicin, vancomycin, gentamicin, rifampicin. This is the antibiotic regimen. How can we prevent this? Antibiotic prophylaxis should be done whenever you are doing dental surgery or any type of surgical procedure. Antibiotic prophylaxis can prevent infective endocarditis. Okay, this is about infective endocarditis. Any doubts in this? Infective endocarditis? Any doubts? No? Okay, okay. We'll move on to the next topic, rheumatic heart disease, rheumatic fever. So, what do you understand with the term rheuma? Why it is called rheumatic fever? Does it have something to do with rheumatology? Does anybody know what is rheumatology? Rheumatologist. How will you become a rheumatologist? Okay, Rohit said autoimmune. Okay. Joints, rheuma. Okay, rheuma means joint. Yes. Anybody? Why the name rheumatic fever? Why the name rheumatic fever? Immediate immune modulation. Okay, immune modulation is there. Yes. Any more? Why the name rheumatic fever? Acha. Okay. See, in olden days, in Greek mythology, they used to think this rheuma. Rheuma means flowing. Okay. So they used to believe this fever occurs when bad bile, black bile, that's very good. So black bile is flowing through your body. They used to think, okay, then only this fever occurs. So since then, this rheumatic fever was named. So in rheumatic fever, what flows? The joint pain flow, joint pains. Okay. So that's why migratory joint pains will be there. Meaning, meaning, meaning. So if it is a right, right side of the body, left side of the body, right shoulder, left shoulder, right shoulder. If the patient complains of right shoulder now, tomorrow he will complain of the pain in the left shoulder. Then after that, he might complain the pain in the left hip, right hip. So in this way, all the major large joints are involved. And imagine who is the patient here? Child is the patient, and that too a school going child. ठीक है, school going child complaining of this migratory polyarthritis. Does anybody believe? Like, will anybody believe in this? They will think, okay, अरे अरे नखरे कर रहा है स्कूल जाने, बहाने कर रहा, he is making excuses not to go to school. So in this way, this condition can be neglected. ठीक है? Okay, rheumatic fever. Rheuma means what is flowing, flowing fever. It means. So what is flowing here? Joint pain is flowing. Okay. Okay. What it is? Inflammatory disease affecting the four structures in the heart, joint, skin, and the CNS. So why only four structures, sir? I'll tell you. I'll tell you. But rheumatic is an inflammatory disease affecting these four structures, and it is always initiated by gas. Okay. Okay. कौन लगा रहा? गैस लगा रहा. ग्रुप ए स्ट्रेप्टोकोकल इन्फेक्शन. ठीक है, द पॉजिटिव एजेंट इज गैस, स्पेशली विच बैक्टीरिया? पायोजीन्स, स्ट्रेप्टोकोकस पायोजीन. व्हाट इज हैपनिंग हियर? In streptococcal pyogene, it will first affect the throat. So any child coming to you, school going child coming to you with throat pain, always prescribe antibiotics, because you want to kill the strep there and there only. So if you wait, if you don't start the patient on antibiotics, and if you send the patient telling ki nahin nahin nahin, jao gargle karo, do betadine gargling, do this warm water gargling, etc. So such you are keeping the burden on the child's immune system. The immune system of the child will take a longer time to form antibodies. So if the child form antibody, the problem with this is the antibodies will also attack the self tissues because of molecular mimicry. The streptococcal antigen have similar structure to the antigens of heart, joints, skin, and brain. That's why only these organs are affected. Okay, why only these four organs are affected? Because the antigens present in these organs, they share molecular mimicry with the streptococcal antigen, especially the N proteins. Okay, so because of this, what happens? Antibodies will also attack the antigens, the self antigens. Basically, antibody mediated damage is happening, leading to type 2 hypersensitivity reaction. Okay, type 2 hypersensitivity reaction. Okay, this is the rheumatic fever. What will you see in rheumatic fever? The Jones. Okay, criteria, Jones criteria. J for joints, O, okay, heart, that is carditis, N for nodules, subcutaneous nodules, E for erythema marginatum, S for Sydenham's chorea. So erythema marginatum, as you can see here, this erythema, non-tender erythema, serpentinous pattern. This is erythema marginatum, and this is Sydenham's chorea. See, abnormal involuntary movement, Sydenham's chorea. So carditis may will have murmurs will be there depending on what is involved, systolic murmur or diastolic murmur. If right side of the heart is involved, we see tricuspid stenosis. If the left side of the heart is involved, mitral stenosis, which is most common in rheumatic fever. Mitral stenosis is most common. Okay? Then aortic stenosis, then followed by tricuspid and pulmonary. Okay? So right wale baad mein aayenge, left side of the heart is more affected. Murmurs, pericardial rub, that might cause SOB, chest pain, palpitations, etc. etc. Joints we already talked about, migratory valley, skin erythema marginatum, I showed you about this. Subcutaneous, they are painless nodules, subcutaneously, especially felt over the bony prominences. Okay, bony valley. So whenever the child was complaining about this large joint, pain in the large joint, if you press the large joint, you will find some subcutaneous nodules. Okay. So Jones criteria you use for diagnosis. How can you diagnose? Two major or one major and two minor here. So notice the difference. In Duke criteria, three minor was there, because infective endocarditis, three predisposing factors should be there. That's how you remember this. So criteria may do not get confused. Investigation may lab you can do for throat culture, ASO titer. This is to detect step, and this is to detect the inflammation. This is to detect the WBC count, CBP. Why WBC count we want? Because minor criteria is increase in WBC. Increase in WBC is one of the minor criteria. Okay, minor criteria we have fever, arthralgia, WBC, increase in acute phase reactant. The CRP and ESR are the acute phase reactant. Okay, CRP. Then we have increased PR interval. I'll tell you what is increased PR interval. So we have 5 minor criteria and we have 5 major criteria. Okay. 5 minor, 5 major. Okay. Okay. You do imaging, ECG, echo, and chest X-ray again. Same thing. How do you manage this condition? Bed rest. Okay, that can be done. Bed rest. Don't ask the patient, that is child, not to go to school. He'll be very happy. You have to give antibiotics plus anti-inflammatory here. Give antibiotics plus anti-inflammatory. So antibiotics mean, what do you want to give? Penicillin, because you want to kill the strep. Strep can be killed by penicillin. If the patient is allergic to penicillin, give erythromycin. 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 Erythromycin is the father of azithromycin. Okay. Azithromycin. Okay, anti-inflammatory, give anti-inflammatory to relieve the joint pain and all those carditis features. If the patient develops chorea, give haloperidol or valproate, which are the relaxants, sedatives. Okay, we did management. Now, we don't want this rheumatic fever to reoccur because rheumatic fever has 50% chance of recurrence. It will always recur. So in such patients, to prevent recurrence, you have to do long-term prophylaxis. So if this is the first symptom, first time the patient came to you, you put the patient on antibiotic for 5 years. For 5 years. So imagine how cruel that disease is. You are keeping the patient daily. You are keeping the patient for antibiotics for 5 years or until 21 years of age, whichever is longer. Okay? Or if carditis is developed, patient develops some carditis like friction rub or something like that, but there is you have to cure that. There is no residual heart disease, so you keep the patient for 10 years, antibiotics for 10 years. If there are some residual heart disease, like patient develop mitral stenosis, but mild condition is there is heart disease is there, lifelong antibiotic prophylaxis must be given because that can lead to infective endocarditis. Okay, what are we studying? Rheumatic heart disease. Where are we? Okay, etiopathy we studied. Gas was a bacteria because of molecular mimicry, type 2 hypersensitivity, all these. Jones, okay, that features are there. Major, minor, two major, or one major and two minor. Okay, investigations we did. Always remember CBP. Students they forget about doing CBP. CBP should be done to know the WBC count in this case. WBC count because which is a minor criteria. Okay, give antibody management that you can do. Yes, okay. Any questions in rheumatic heart disease? Any part of this that you want me to repeat? Rheumatic heart disease ka? No? Okay. Moving on to the next topic, angina. What is angina? Angina means chest pain, right? Chest pain. But important thing that you have to remember is chest pain. Why chest pain is occurring? Because of ischemia. That is, what is ischemia? Inadequate blood supply to the heart muscle. So heart muscles start to die, but they will not, permanently damage will not occur. Ischemia means temporary cessation of blood supply to the heart muscle. That is angina. Angina and myocardial infarction, there is a difference. In myocardial infarction, there will be myocardial necrosis, that is permanent damage to the heart tissue occur. But in angina, it is a temporary, a block in the blood supply. That is insufficient oxygen supply is temporary. There is no, without myocardial necrosis it will be. Okay, that is angina. Angina, what are the causes? CAD, most common cause, then CAS, coronary artery spasms, or some stenosis, aortic stenosis. So you remember, no, coronary arteries, they arise from this area only, near the aortic bulb. So if aortic stenosis is there, that can be a cause. Hypertrophic cardiomyopathy, again, rare causes. These are the risk factors where CAD can occur. Everybody know these risk factors, how to stop smoking, hyperlipidemia, hypertension, all the risk factors. Okay. I need your focus here on this point. The heart's oxygen demand increases during exertion. Okay. What are the exertions? Stress or cold atmosphere, or the patient is doing exercise. When the oxygen supply, the heart's demand, when the demand increases, supply should also increase. But if supply is inadequate to meet the demand, then angina occurs. Everybody followed, no? When there is supply inadequate, then only angina occurs. Okay, this is about angina. Angina is temporary stop in the blood supply of heart will lead to chest pain. That is angina. Permanent damage due to this temporary stoppage, that is known as MI. We will talk about MI also. What are the types of angina? Stable angina. Stable angina, when we say stable angina, if the pain lasts only for 1 to 5 minutes. If it is not resolving even after 20 minutes, we say that is unstable angina. Unstable angina. Okay? What is Prince Mitchell angina? Special type of angina, not due to CAD, but it is due to coronary vasospasm. Coronary vasospasm. Okay. So in such patients, you don't treat CAD management. You give vasospasm, vasodilator wale management. Okay. Vasodilators you give in Prince Mitchell angina. Decubitus angina, angina occurring when the patient lie down. Okay. So what is the typical sign here? Fist over the sternum. Fist over the sternum due to pain. That is Levine sign. Okay. So all these signs of PVD, increased heart rates, excessive sweating may also be there. But remember, the increased this chest pain, due to increased chest pain, the patient will keep the fist over the sternum. Try to bang the sternum and reduce the chest pain. Okay. This is about angina. How are you going to manage? If you don't manage first, what will happen? Myocardium. It will go into permanent damage. Permanent damage. Prolonged ischemia. Then we heart failure. Or if heart failure is not there, then at least arrhythmia might be there. Why? Because electrical system, conduction system is disturbed. Cardiac arrest. Severe ischemia if it involves a large portion of the heart leading to cardiac ischemia. So I'll take a moment here and I'll ask you, how many coronary arteries do you know? Anybody? Please unmute and tell. How many coronary arteries do you know? Yes, hello. It's okay. How many coronary arteries do you know? Okay, basically I'm asking about the blood supply of heart. Hello, yes. Can you please unmute and tell? Okay, Akhil. Uh, who are they? Yes, Shalini, Dikshita, Zubair. How many coronary arteries do you know? Okay, I'll draw a diagram here of the heart. Okay, okay. So two coronary arteries, everybody know two coronary arteries. So this is the right side of the heart. Right side of the heart is supplied by right coronary artery. Okay? Right coronary artery. Broadly speaking, why I don't know anatomy. Okay. I also don't know. I am with you. I don't know anatomy. Not going deep. So right coronary artery, left coronary artery, left coronary artery. What happens as soon as left coronary artery is formed? It will divide further to give rise to left circumflex artery and left anterior descending artery. Okay? This is what you need to know. So the main arteries which are involved in this coronary artery disease, because of which angina can keep occurring, or coronary artery or MI also can occur, is because of these three arteries: RCA, LAD, LCA. Okay. LAD, LCA are the two branches of LCA. Left circumflex coronary artery is a branch of left coronary artery. Okay. 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 This is the basic. Why I'll tell you. We'll read more about this in MI. So where are we? What are we doing? Investigation. Yes, we need investigation. Which investigation we need? ECG. ECG. What will you expect to see in ECG? ST depression. Remember ST depression. ST depression is what the characteristic finding in the angina. ST depression, T wave inversions. So normally ST will be, oh, if this is the baseline, so I can draw, this will be my P wave, this will be my Q, and this will be my R, and this will be my S, and then baseline, then this will be my T. Okay? So P, Q, R, S, and T. Now, I'll draw the similar diagram on the top side, but on the angina patient. In angina, what might happen? P wave will be like this. Okay. P wave will be like this. Q also okay. Q, R, S, T. Okay. Notice the difference. P, Q, R, S, and T. See, T wave was on the upside here. Okay. I'll color this. Okay. Okay. See here. This picture. Normally T wave should be on the positive side, but here T wave inversion occurred. And ST, S segment, see it was on the baseline. It was on the baseline. Normally it was on the baseline. But here it is above the baseline. So ST elevation it is. Okay? See ST elevation. So such MI is known as ST MI. Opposite of this is ST depression. So in ST depression, this line will fall below the baseline. So in angina, ST depression and T wave inversion will be there. ST depression and T wave inversion will be there. Okay. I'll tell you why it is important. I'll tell you in MI. Just remember for now, ECG, in ACG, ST depression will be there. If the patient is developing a mild angina, like stable angina, like he is developing chest pain for 5 minutes and the chest pain is going like on its own, there is no intervention needed and it is going on its own. For such patient, you do something as treadmill test. Like you put the patient under exertion, and you take the ECG simultaneously, and at that time you notice under exertion how is the heart performing. So if you find even ST depression, then it will confirm myocardial ischemia is there. Okay, and you can give troponin levels to check for MI. Echo can also be done. Angiography can also be done if you are suspecting coronary artery disease. Block in the coronary arteries, you perform coronary angiography. Okay, any doubts till now? No. So now we'll treat angina. How are we going to treat? What is happening? Why angina occurs? Myocardial ischemia, meaning there is something which is blocking the circulation. So what you will give? You give dilators, the powerful quick onset dilators you give. Nitrates are the powerful quick onset dilators. Long acting nitrates, short acting nitrates. Then what is happening? Due to this block, the blood was getting pooled. No here. So whenever there is stasis of the blood, what will that happen? What will that lead to? Thrombus. Okay, thrombus. No, it will lead to thrombus. So thrombus, you don't want thrombus to be formed because if thrombus is formed, what will happen? This cell which was supplied by this artery, this cell will undergo necrosis. So you don't want the thrombus to happen. That's why you give antithrombotic agents. These are antiplatelet agents, and antithrombotic agents are antiplatelet agents. Tenecteplase, fibrinolytic agents. In MI also will give. I'll tell you about this. Just remember antiplatelet agents. Why are we giving antiplatelet agents? Because you have to prevent this thrombosis. Why thrombosis was occurring? Because any stasis of blood will cause clotting. To prevent that clotting, give antiplatelet drugs. Okay, ACE inhibitors, beta blockers, all are vasodilators. Calcium channel blockers also vasodilators to increase the myocardial blood supply and prevent further prolonged ischemia. This is about medical treatment. If imagine the patient is not responding, the patient is having unstable angina or Prince medal angina. For such patient, we have PCI. What are we doing in PCI? These are the radiological intervention. Like this is not a surgery. It's a radiologist. The one who do DM in the radio diagnosis. They are able to perform this time. Or cardiologist. What they'll do? They will go. For example, this is the blocked artery. Okay, blocked artery. Let it be most common is left anterior descending one. So this is the blocked artery. So what they'll do? There is something which is blocking. So they'll take a guide wire. They'll remove this block and they will put a balloon here and they will dilate this artery. Okay. So after dilating, it will look like this. So there will be one balloon, and that balloon they'll take it off, leaving a mesh. This mesh will keep this artery open. So you see it is balloon angioplasty with stent placement. This is known as stent. Okay, stent means this. If you are not able to perform this PCI, or if this obstruction is large, you can do open heart surgery. That is CABG, coronary artery bypass grafting. What you will do here? You will cut down this artery, okay, and you will take one graft. You remove this blocked segment. You remove this blocked segment. You will take the graft. Let's say the graft is of purple color. You will suture it. Okay, this is only CABG procedure. What are we doing? We are trying to restore the blood supply so that the end of this myocardial cell will get the blood. Okay, so this is about angina. How do you manage a mild case of angina? How do you manage unstable case of angina? How do you manage Prince metal angina? This is only the management. Okay, this is how you manage angina. Everybody followed angina? If you follow, then it will become very easy for MI. Okay, now MI. This documentary, very good documentary, the video maker. You must go and watch this documentary. This is only about MI, myocardial infarction. What is myocardial infarction? See, as the name implies, there is death. Death. Why there is death? Because of prolonged ischemia. Okay? If we don't resolve angina, if we don't resolve unstable angina, it will cause MI. So again, etiopathogens is same. CAD is a mnemonic. CAD, coronary artery disease because of atherosclerosis. All those risk factors you can write in this case. CAD is a mnemonic. CAD. What are the non-atheromatoous causes? This is 10% causes coronary vasospasm. Already talked about coronary vasospasm. Which angina? Prince metal angina. Okay? Prince metal angina. Everybody followed? Prince metal angina? Hmm. Other reasons are some vascular, some inflammation is blocking the blood supply, or some amyloid is causing narrowing of the lumen. Again, some hematological disorders like sickle cell anemia are blocking the blood supply. So, any type of reason, the main concept here is infarction. Why it occurs? Because prolonged ischemia. So this is a cell with a blood supply, and cells, there is a block in the blood supply. So blood is here only. Blood is not able to come here. Okay. So if the blood, this is temporary, this is angina. Just ischemia is there, angina. With ischemia, if it develops some thrombus, and if you don't resolve that thrombus very soon, if you don't take that out very soon, what will happen? MI infarction can happen. Okay? Which artery is most common artery is left anterior descending. Just now I showed anterior descending valley, left valley. That is most common artery to be involved in MI. Okay. Why it can occur? Vigorous exercise. You are doing some exertion, stress. So classical pain of MI, chest pain, 30 minutes, more than 30 minutes, because we need more. We need more than 30 minutes. Then only that thrombus will form. Okay. That angina only 1 to 5 minutes was there, stable angina. And unstable angina more than 20 minutes. Here MI more than 30 minutes. Okay? Crushing type or squeezing type, patient will radiate to the neck, left shoulder, and left arm. Always remember, MI can mimic peptic ulcer disease. MI can mimic peptic ulcer disease. Okay? MI can mimic peptic ulcer disease. Epigastric discomfort can be there, and it will always have this diaphoresis, sweating, cool, clammy skin. Okay? Diaphoresis will always be there. This is about MI, myocardial infarction. What are you expecting to see in MI? Chest pain, sweating, epigastric discomfort, crushing or squeezing type of chest pain. Okay. How are you going to diagnose it? How do you diagnose the death of a tissue? You need biopsy, for that, right? To diagnose death of a tissue, how will you tell the diagnose of the death of a tissue? Anybody? I'm telling what is MI. MI is death of cardiac muscle. How are you going to prove that cardiac muscle died? Anybody? Are you following? Those who are following, just raise your hands. Okay. 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 See, my question is, I told MI is death of cardiac muscle. How are you going to investigate? You need investigation. No, you need to diagnose. No, that this is death. How are you going to investigate? You need to take biopsy. No. So the death, why it occurs? Because of ischemia. So always remember, just look at this jar. So it is like a dead cell. Okay. So a dead cell was like, this jar, when we cover this jar with a lid. Okay, the lid, then the content will remain inside. The contents of the jar will remain inside. If we cover this jar with a lid, okay, the contents, all the contents of the jar will remain inside. What was this lid? It was a plasma membrane or a cell membrane. But as soon as any cell dies, this lid will go away. First, the lid will fall. As soon as the lid falls, the content of this jar will come out easily. In the same way, myocardial cell also, whenever there is death of myocardial cell, see, this is the blood vessel which was supplying this myocardial cell. As soon as there is death, there is prolonged ischemia, due to some prolonged ischemia, prolonged blockage, there is death of this cell. This cell's plasma membrane will go, and all the contents of this cell will be transferred into this blood vessel, and it will wait. So as soon as we resolve this, as soon as we remove this thing, these will come out. These content will go into the main circulation. So these are known as markers of cell death. So there are some specific markers, like the myocardial cell contains some specific proteins. Any cell will contain protein. So cell की जायदाद है वो, the jewelry of a cell is a protein. ठीक है. So what proteins do myocardial cell like to wear? So they like to wear these proteins. Myoglobin will be there because it is a muscle. CKMB will be there and troponins will be there. ठीक है. Among these, which is the earliest to rise? Myoglobin is the earliest to rise. ठीक है. Myoglobin, which is most sensitive, that is, myoglobin is earliest to rise, but it is not specific. Which is the most specific? Troponins, cardiac troponins. That's why we do troponin test only. Okay, cardiac troponins. So these are the markers. LDH also can be right, but it is not a specific marker. In ECG, yes. Now comes the main topic. See, this is endocardium. Like, okay, I'll give you an orientation. We told, this. I will drawing like this for a heart. Okay. So these are the four chambers of heart. Now imagine I have taken this, this section, and I'm enlarging this section here. Okay. So what do you see? The first, and inside of the heart, the first layer is an endocardium layer. Okay, endocardium. Then beneath the endocardium, what are you expecting to see? Myocardium. Then above the myocardium, what will you see? Pericardium. Okay, pericardium. Okay, everybody knows this, no? Yes, yes. Now the blood supply to the heart is from inside to out. Like, for example, if this is a coronary artery, if it is, imagine this is a coronary artery. So the blood from coronary artery will go from inside. Like first the blood go to endocardium, then the blood go from endocardium to myocardium, then to pericardium. Okay, this is how there will be a distribution, supply. So now tell me, if this coronary artery gets blocked, which is the first region where I can see this ischemic symptoms? The first region where we will see is endocardium, right? Endocardium will be affected. Okay. So the first thing, that is, if it is a temporary blockage, what I will see? I will see subendocardial implant. Okay. Subendocardial infarct. So in subendocardial infarct means the infarct is just beneath the endocardium. Now, if this ischemia, like if the patient will present at this stage, what the patient main complaint will be angina. If you don't resolve this angina, if you wait, if the patient does not come even after 30 minutes, now this prolonged ischemia ki wajah se, even myocardium and pericardium will also get involved. So this infarct will extension of infarct we say. This extension of infarct, say the whole wall of the heart gets involved, and this is known as transmural infarct. What do we say? Transmural infarct. Okay. So always remember, in subendocardial infarct, we will see in subendocardial infarct we will see ST depression. Okay. Okay, ST depression. In transmural infarct, we see ST elevation. So if MI involves transmural infarct, so we say STEMI. It is a STEMI, meaning ST elevated MI, meaning severe type of MI, involving the total layer of the heart. If you don't intervene now, if you don't manage this transmural infarct, then what will happen? What is the next step you tell? So this whole layer, this whole okay. See the whole this whole wall is become damaged. No, the whole total layer of the heart. This specific region has no blood supply, so this region will become weak. All cells in the region will die. Now what will happen? This region will break off. This will perforate. Okay, so this region perforate, leading to what? Outside internal bleeding. Okay, so you have to transmural infarct like STEMI cases. STEMI cases you have to take seriously. So how will you diagnose whether it is STEMI or not? You do ECG. In ECG, just look at the ST elevation. If it is ST elevation, then it is STEMI. So ST elevation means transmural infarct. Non-ST elevation is subendocardial infarct. Okay, this is the basic concept that you have to be familiar with. ECG over. E-coma, yes, you can give. See, always the dead tissue will not move. Dead do not move. So if there is hypokinesia or akinesia, kinesia means movement. So if there is less movement or there is no movement at all, then that wall is damaged. Okay. So that is what you are going to see in echo. Echo, you see kinesia, hypo or akinesia. In ECG, you look at ST segment. No matter the lead, wherever the lead is. Okay. So what is these leads? They just indicate where the MI is. It is in the anterior wall or septal region, the inferior wall, lateral wall. So you don't need to focus on that. Just examine all the leads and look at whether ST elevation is there or not. If there is ST elevation, then it is a serious case. If there is no ST elevation, then it is a subendocardial infarct. You can intervene. Okay. Routine test CBP and all and all, just to know the risk factors, you can do same as angina. Management same as angina, but remember MONA. जब दिल दुखता है, remember MONA. What is MONA? MONA is a mnemonic for M for morphine because chest pain. How is the patient? Squeezing, crushing type of pain. So M morphine, O oxygen because there is no oxygen. That's why that is dying. Nitroglycerin. You have sublingual, and antithrombotics. Already talked about why antithrombotics are needed. Yes, aspirin. So antithrombotics you give cocktail, like you give aspirin, clopidogrel, and IV heparin. Cocktail of these drugs because you want to make sure that thrombus is not formed. So give the cocktail of these drugs. This is about the immediate management. Then the reperfusion therapy. What is reperfusion therapy? If you remove the clot by medication, it is fibrinolysis, we say. What medication you are using? You are using the medication to break down the thrombus. Okay. Break down the fibrin. Fibrin is a thrombus. So you break down the thrombus by giving fibrinolytics. What are the two fibrinolytics we know? Naturally occurring is streptokinase or artificially available is TPA. Tenecteplase is the brand name for that. Tissue plasminogen activator. So these are the fibrinolytic drugs. By using drugs you can give, or if if you couldn't do within 12 hours, if the patient came to you late, you can do PCI. Already talked about PCI, CAPG also we talked about. Okay. In MI, this is how first heart attack you manage. First heart attack, this is how you manage a patient. Either by doing or immediate measurement the सबका करना है. Reperfusion therapy, if the patient is very lucky, he came to you within 12 hours, do STEMI, do fibrinolysis, or after 12 hours, you do PCI. If PCI is not available, if the block is large, you do CAPG. First time you did. Very important. After doing this, you have to keep the patient on long-term therapy because it means cardiac wall is damaged. No. So you do beta blockers, ACE inhibitors, or ARBs. Why are you doing this? Because we want to decrease the heart rate. So if by decreasing the heart rate, will there be anything like any problem to the patient? See, by decreasing the heart rate, what are you trying to do? You are trying to decrease the load on heart. Okay, in 1 minute, how many times the heart should contract? You are trying to decrease that load on heart. So you are trying to give heart the time to heal from the injury, from this insult. Okay, ACE inhibitors, ARBs, they are perfect drugs because they are known to cause remodeling of the heart. They not only prevent the damage, they also cause remodeling of the heart. So you give them lifestyle modifications, yes, smoking cessation, you can write. And always remember, we are doing this defibrillator we are implanting for high risk patients, especially those patients who have genetic disorders or they are more prone to develop this MI. Recurrent cases, you can plant a defibrillator. This is about MI, heart attack, very important. Whenever you do ICU duties, in internship, MI cases will come, and this is how you manage them. First, remember the mnemonic, MONA, then antithrombotics, then reperfusions. Reperfusion वाला cardiologist आके कर लेता, that cardiologist people will do, बट आपका काम है मोना. ठीक है, मोना नहीं बोलना. ठीक है, just to know MI, heart attack. Yes, yeah, we'll close within a few minutes. Yes, only three topics I think are there: valvular disorder, conduction disorders, and some miscellaneous topics. Everybody followed? Any doubts? Any doubts in MI? Any doubts? Anybody? Yeah, MI की complications. Yes, I'll tell you. See, MI का क्या है? Myocardial infarction. If the infarction is very large, then total left ventricle चले गया, left ventricle failure. अब right ventricle भी चले गया तो cardiogenic shock will happen. Then only selected area is there that rupture can happen. I already told you, endocardium, myocardium, pericardium. That extension of infarct I already talked about. Dilation of ventricular chambers, ventricular aneurysm, selected area is involved. Arrhythmias can occur. Okay, so these are the complications of MI. Yes, and MI complications also. Now we'll talk about yes, valvular diseases. Yes, valvular diseases we'll talk about. In valvular diseases, what do you need to remember? So this is our heart. You know which valve is where? No? Okay, okay, right atrium, right ventricle, left atrium, left ventricle. Okay, okay. We have mitral valve. See, any valvular disorder, it can be of two types. This is my valve. This valve can either become a dilated valve or it can become, lumen of the valve become narrow. So lumen can either become narrow or it can either become large. So mitral, if the lumen becomes narrow, it is stenosis we say. If lumen becomes large, it is either prolapse or regurgitation. Depends. Early cases, prolapse. Regurgitation, late cases. Regurgitation means the valve is not functioning at all. We'll talk about this. So what is it? What is the question? Mitral stenosis. So now you only tell me in mitral stenosis what should happen. You only tell me. Again, I will draw another heart for you. I have so many hearts. Okay. Now, so this is right atrium, right ventricle. We don't need. Now you tell me. This is the mitral stenosis. What should happen? Left atrium, left ventricle. Blood wants to come from pulmonary veins. Pulmonary veins. Blood wants to come into the left atrium from left ventricle. Blood wants to go into the left ventricle. Can this blood pass through the mitral stenosis? Can this blood pass? Anybody? Yes, yes, yes. Yes, I know you are sleepy, but bear with me. These are the basic concepts. If because CVS is so volatile, it will be like रात को रटा सुबह में हवा. It will be like that. Okay. So you will forget very easily. You need concepts. Mitral stenosis. What are you expecting to see? Can this blood pass through the stenotic valve? Yeah, exactly. The blood cannot pass. So it will cause what? It will build up in the left atrium. So left atrial hypertrophy you can expect. Then back pressure into the pulmonary circulation. So again, that signs of all those hemoptysis, pulmonary edema, all those you are expecting to see. Now tell me, anybody, tell me, murmur will you see? Like, will you hear murmur? Murmur will you hear? Yes or no? If there is a turbulence flow here, yes, turbulence flow. So murmur must be there. Now next question, which murmur? Systolic murmur or diastolic murmur? Which murmur should come here? Anybody? Anybody? Systolic murmur should come or diastolic murmur should come? Yes, diastolic murmur should come. Okay, why diastolic you are telling Shivani? Diastole में तो जा रहा ही नहीं ना वो. Diastole में, in diastole, the blood is not able to go at all, no. Only when there is systole, the atria might forcefully push the blood through this narrowed valve. And this forceful pushing will cause turbulence. Then only this happens. So that's why it is a systolic murmur that we are going to see in mitral stenosis. Okay? Okay. Okay. Why? No, no, no. Always remember, if you encounter a case of mitral stenosis, ask for childhood history of rheumatic heart disease. Rheumatic, almost all cases are rheumatic in origin. Other very rare reasons are some calcium buildup in the valve or some infiltrations in the valve leaflets like amyloid, SLE, some infiltrations. So those are the very rare reasons. But most 99% of the cases are rheumatic heart disease. Okay? How will the patient present to you? Dyspnea, yes, dyspnea. Kychodyspnea, pulmonary congestion, backflow. Orthopnea, yes, orthopnea. Why orthopnea? Orthopnea means difficulty breathing and lying down. Because because when the patient lie down, what happens? When the patient lie down, what happens? There is more venous return. More venous return to the patient. That's why orthopnea. More venous return, more difficulty in breathing. PND, yes, due to redistribution. Palpitation may also happen. Right heart failure signs in chronic cases can occur. JVP, edema in chronic cases. And due to this low cardiac output, cardiac output will be low, no? Heart is unable to pump, low cardiac output, peripheral vasodilation can occur. So pink persons will come. Okay. Reddish purple cheeks, malas. These all you seen in chronic cases. On auscultation, what you will find? Loud S1. Why loud S1? What is S1 सबसे पहले? Why S1 occurs? Anybody? Why S1? S1. S2. Why S1 occurs? When the blood from atria is pushed into the ventricle, what happens? During atrial systole, what happens? Blood from atria is pushed into ventricles, right? Now, when ventricle systole happens, what happens? The blood should not go back into the atria. So, forceful closure of AV valve will create S1. Okay. Then S2, when it occurs, when ventricle systole happens, blood will go into the pulmonary artery from right side, aorta from left side. So then diastole happens. So during diastole, that the blood which went into those arteries, they should not come back. So forceful closure of semilunar valves will create this S2 sound. Okay, semilunar valve closure. So this is S1 lub, this is tub. Okay, it's basics. So now tell me loud S1 because this is AV valve. Mitral valve is AV valve. So we have S1 systolic murmur. Loud S1. Okay, loud S1. Then there will be opening snap. Yes, opening snap will also be there. Now, how are you going to manage this case? Anybody? Anybody? Stenotic valve, any management? Just to decrease the workload, all these things can be done. Yes, to decrease the workload on the heart. Surgical intervention, how are you going to intervene? Repair the valve, that is valvuloplasty, or replace the valve, valve replacement. Valve replacement. Okay? Same ECG, chest X-ray, everything will be there. In echo, you will find everything. Echo can be done. Same, you have to write. Okay, MS over. Any doubts in MS? Any doubts in MS? Okay, somebody is asking, say, what type of murmur in the mitral valve? Mitral valve, MS diastolic. Yes, diastolic number already written. Yes, diastolic murmur. Okay, okay. Now MR. Okay, what is MR? MR means regurgitation. Regurgitation due to because valve is not closing properly. Does not close properly, leading to regurgitation. Why valve does not close properly? It can be either primary reason or a secondary reason. Primary means there is a valve problem with the valve. Degeneration is happening in the valve. So the first most common is mitral valve prolapse because it is early change mitral valve prolapse. Then the rare causes are these: rheumatic heart disease, trauma, infective endocarditis are the rare causes, or congenital weak valve is the rare causes. So primary cause is degenerative conditions. Secondary cause is functionally the valve is not closing properly. Why? Because left ventricle is more dilated. There is some coronary artery disease, or there is hypertrophic cardiomyopathy. The big heart is there. So there are these other causes. Now, MR में what are you expecting to see? Again, all these conditions, dyspnea, fatigue, palpitation. But remember, you will see third heart sounds and display the bicycle impulse if it is due to left ventricular heart. Okay. And here you are able to find holosystolic murmur in MR. During the whole systole, MR will be there. Where this best heard? Axilla. Okay. Best heard towards axilla. Then how where diagnostic test, echo you can do, ECG again same, everything is same. What are you expecting to find here? This left atrial enlargement can be done, and the management is same. Reduce the workload on the heart, do either repair or replace the valve. Okay, repair or replace the valve. Repair or replace the valve. If you don't do that, then same complications can occur. Already talked about similar complications, everything is same. CCF, congestive cardiac failure. This is important. Congestive cardiac failure. Yes, somebody is asking why diastolic murmur. In which diastolic murmur? In MR. MR is systolic murmur. MR, not diastolic. Yes, Yogita. In which MR? Okay. In MR, systolic murmur. In MS, diastolic murmur. MR pathogenesis you want. MR. See, valve regurgitation. Regurgitation means what? The valve leaflets of the valve. See, this is the normal valve structure. Okay. So the valve have some leaflets. So depending on how many leaflets it has, it can be bicuspid or tricuspid. So normally the closed valve should look like this. The open valve should look like this. Okay. So if the valve, is not closing properly, if the valve is not closing, this is closed valve and this is the open valve. If the valve is not closing properly, then we say the valve is regurgitated, meaning it is partially closing, it is prolapse. If it is not closing at all, that is regurgitated valve. Why it is not closing? Because leaflets are non-functional, degenerated, or it is trying to close, but the heart is large. So the large heart means valve also becomes stretched, no? Stretched. So this stretched the valve is not able to close. So that is this functional causes of MR. Okay. This is why MR can occur. Now, same, everything is same. Like congestive cardiac failure we were talking about. Yeah, congestive cardiac failure. Heart failure can occur due to three reasons. First, heart is unable to pump, or there is workload is more on the heart, or heart is unable to get filled. Okay, impaired filling. Intrinsic pump failure, that is weak myocardium, more load on the heart, or there is filling defect on the heart. So due to three reasons, based on this, the heart, that they have classified into a systolic failure or a diastolic failure, or failure in systole, they say, that based on this, heart failure can be right side or left side heart failure. And remember, the common symptoms that we talked about in heart failure. In heart failure, what do we see? Left side heart failure. In left side heart failure, dyspnea. So all those symptoms like hemoptysis can also be seen here. Left heart failure. Right heart failure, remember the edema and JVP. These are the main in right heart failure. Causes, yes, left heart, MI. Right heart failure, yeah, we talked about embolism, hypertension, core pulmonary stenosis. All those we talked about. Investigations, X-ray, ECG, echo, same, everything similar. But the main difference is ANP. ANP and BNP levels are rising. If ANP, BNP levels are rising, it means that heart is failing. Okay. How do you treat this? You have to treat the underlying causes. Okay. What all the causes are there that you have to treat? How will you treat? First, inotropic drugs you give to increase the pumping. Main inotropic drug, digoxin or dobutamine. If the patient have, some renal injury, AKI also, you give dopamine. Dopamine works on the heart and increases the heart rate and also dilates the renal blood vessel. Okay, so dopamine is that is very good drug. Vasodilators, yes, vasodilators, and to arrest the progression of disease, ACE inhibitor. Already told, it will remodel. Okay, remodel. Then last, cardiac transplantation for very severe cases. If the heart has ejection fraction, very less ejection fraction, less than 20%, go for cardiac transplantation. So all the circulatory disorders have been finished now. Now only conduction disorders remain. Okay. What is conduction disorder? Conduction means you need to know electrical conductivity of the heart. See, electrical conductivity impulses originate in SC nodes. Then from SC node, they go into the AV node. And from AV node, they go into bundle of phase, then papillary musculation, then ventricular musculation. Okay. So you have to remember this. From SC node, it goes into the AV node. Where is SC node? Right atrium. Where is SC node? Right atrium. Where is AV node? Near the junction. Okay. Near the junction. AV node is there. Now, so in conduction disorders, either SA node will they have so much. Uh, it is called pacemaker. Pacemaker means it will discharge it rapidly. The rate at which the rate of firing of SA node is almost around 100 to 200 beats. So that is the rate of firing. That is why it is known as pacemaker. In conduction disorders, we study about fibrillation, AFib, or atrial flutter. So first, let's talk about what is the difference between fibrillation and flutter. See, flutter means atria beat regularly but faster. Meaning what? In 1 minute, 250 to 350 beats we can see. This is fluttering. Flutter, regular atrial beat. So how will be the ECG? As you can see here, ECG will be sawtooth, like regular pattern you see. This is the ECG, atrial flutter. AFib in AFib, what is AFib? Arrhythmia it is. It is arrhythmia. It is no regular. Atria beats irregularly. Atria beats irregularly. And if you closely observe, there is no P waves. No proper P waves. See, P wave is there, but P wave is not there. So no P wave, T wave is there. T. So this is T wave. But there is no P. P is not there. See, only T wave is there. So this is the atrial fibrillation. Atrial fibrillation. It is an arrhythmia. Atrial fibrillation is arrhythmia. Okay, so what are the causes? Causes stress, caffeine, mostly hyperthyroidism, all those hyperactivity causes. Okay, that is about AF. So EF, always remember irregular. AF, atrial fibrillation is irregular. Fibrillation is irregular. Okay. In JVP, loss of A wave can be found. Yes. ECG, echo, routine test can be done. Yes. How are you going to manage? If the patient is unstable, start anticoagulants because the arrhythmia always predisposes into thrombotic disorders. So you give anticoagulants first, then you shock the patient from 100 to 200 joules. Shock the patient. Stable, hemodynamically stable patient and AF is of less than 2 days duration, do the same treatment. If the AS is of more than 2 days, okay, do not shock. Do not shock. Why? Why? Because if the emboli have been formed 2 days, 2 days, the emboli takes 2 days to form. The emboli has been shocked. You will displace that emboli, leading to stroke. Okay. So in as unstable or as stable, AFib unstable or stable. Stable less than 48 hours. All the cases use shock. Shock, leave anticoagulants. Then later, to control the rate, give blockers or chronic anticoagulation also can be done. And you can do ablation. Ablation procedures to know the cause. If the cause is due to extra node, you do ablation. You destroy that node. Destroy that node so that proper conduction should occur. Okay. Then about the heart block. What is heart block? Heart block means normally from SA node, the impulses travel to AV node and then distributed to the rest of the structures. So there is some delay at the AV node. That is known as physiological delay. If the delay is prolonged, we say there is a block in the conduction or a heart block. Okay, heart block. So heart block. Heart block, if it occurs in the AV node, it is known as AV block, atrioventricular block. On that, questions are coming. So AV block. What is the cause for AV block? If the heart, if there is no proper myocardium, there is fibrotic myocardium, that conduction tissue is only not there. There are some drugs which will cause heart block. Because of this, some potassium disturbances, because of this, AV blocks can occur. Okay, AV blocks. AV blocks means what? The impulse is not progressing from AV block, from AV node. It is not progressing to other Purkinje fiber bundle of physenol and all. It is not progressing. So if the block is delayed, like it is first degree, we say. If the block is intermittent, we say second degree. If there is complete block, we say third degree. Okay, complete heart block. Okay. What are we studying? Where are we? We are in conduction disorders. In conduction disorders, we told it is AV block. What is AV block? AV block means from SA node, the impulses are coming to AV node, but from AV node, there is no further progression. Okay. If it progress, but after some time it progress, then we say it is first degree block. Okay. It is normally progressing, but sometimes it is not progressing. This is intermittent second degree block. If it is not at all progressing, then we say it is complete block, third degree. Okay. So how are you going to find which is what? In ECG. In ECG, if you are finding this this PR interval, meaning the interval, the time between P wave and R wave. Normally, this time should be less than these three boxes, small boxes. But here, as you can see, the time between P and R is how many boxes? 1, 2, 3, 4, 5, 6, 7. So more than 3 boxes. It means PR interval is prolonged. So prolonged PR intervals indicates there is delayed conduction. Conduction is happening, but there is delayed conduction. That's why it is first degree AV block. Okay. AV block में PR, only PR interval will be more in first degree. In second degree, what happens? Intermittently, there is no conduction. Okay. So based on that, it is of two types: type 1, type 2. In type 1, PR interval will be there, but progressively it is elongating. Okay. As you can see here, PR interval was, let's say it is 1. Now you see it is progressively elongating, progressively getting elongated. It is more than here. Okay. Until one P wave, no P wave will be able to follow QRS. Okay. Until there is no conduction. So this is known as type 1 block. Type 1 block. So it is an intermittent node to type 1 block. In type 2 block, what happens? There is regular fixed PR intervals, but suddenly no QRS will come. Okay. In type 1, slowly, PR interval gets prolonged and directly one QRS will not come after a small PR interval. But in second degree, suddenly, even PR interval is fixed. Even if PR interval is fixed, there is suddenly one QRS complex will be absent. This is type 2 block. Okay, conduction fails suddenly. Suddenly. Okay, what are we studying? What are we studying? We are studying conduction block. So conduction block may be told कि SA node to AV node conduction happens, and from AV node further conduction happens. But if conduction is not getting further extension from the AV node, if it is not traveling to bundle of Purkinje fibers, we say hard block. So in hard blocks, there are three types: first degree, second degree, third degree. So hard block, delayed hard block is first degree, intermittent hard block is second degree, and no hard, like no conduction at all, is third degree. Okay. So what is third degree? So in third degree, as you can see, AV dissociation, meaning what? See, P waves. P waves, where are the P waves? See, this is a P wave. P wave is not followed by a QRS complex. This is the P wave. Again, P wave, P wave. So after P wave, no QRS complex occurs. So atria and ventricles beat independently of each other. That is AV dissociation, we say. This is complete heart block. Okay. Very simple heart block, very simple. How will the patient present to you? With all the signs and symptoms of the causative disease. Plus, when doing ECG, you will be able to find this heart block. How will you manage? So mostly you do symptomatic management. Okay, symptomatic management, meaning what? If it is second degree or third degree, give atropine. Atropine increases the heart rate. Atropine increases the heart rate. Atropine. If the patient goes into systolic, like asystole, like flat line on ECG, give IV plus IV. Dextrose until a pacemaker is inserted. Okay. This is about AV blocks. This is how you manage AV block. Clear, everybody? Any doubts? This is a very confused topic by most of the students. See, AV block. Remember, it is a block in conduction after AV node. Okay, after AV node, no conduction is happening. Okay. First degree, second degree. See, in second degree, prolongation of PR interval until a P wave is not followed by a QRS complex. Second degree, type 2. Here, fix the PR interval, but suddenly there is QRS complex, no QRS complex you feel. Okay? So it is about second degree. Whenever there is second degree or third degree, give atropine. If there is asystole, give IV atropine with dextrose. Okay? This is how you manage AV blocks. Any doubts in AV block? No? Okay, coming on to the last question, cardiomyopathy. Cardiomyopathies are, they are primary disorders where myocardium is getting enlarged. Myocardium, due to some reason, myocardium is getting enlarged. Myocardium is getting enlarged. Okay? Myocardium, due to some reason, myocardium is getting enlarged. So if it is, dilated myocardium, this is dilated cardiomyopathy, meaning this is a normal heart. If this is a normal heart, dilated means the heart will be like this. Okay? So this is normal. This is dilated cardiomyopathy. So when it occurs, autosomal dominant transmission and only treatment is heart transplant. Heart transplant. Okay. All the symptoms of heart disease will be there. The only treatment is heart transplant. That is what you have to know. Now, hypertrophic cardiomyopathy. Now, how hypertrophy will be? If this is a normal heart, hypertrophic cardiomyopathy will be like this. Okay. If it is normal heart, this is hypertrophic cardiomyopathy. Okay. Normal heart, hypertrophic cardiomyopathy. All the symptoms are easy, but same autosomal dominant transfusion. But here you can try some, some surgeries. Myectomy you can do, septal ablation you can do, beta blockers you can do, something you can do. But in dilated cardiomyopathy you cannot do. Once the heart is dilated, you cannot, constrain, reduce the size of the heart. This is about that. Hypertrophic cardiomyopathy. Arrhythmogenic ventricular cardiomyopathy not being restrictive cardiomyopathy. What do you mean restrictive cardiomyopathy? Restrictive cardiomyopathy means, see, if this is a normal heart, now something outside the normal heart is restricting its movement. So, like for example, a constrictive pericarditis or some cardiac tamponade. So this is restrictive cardiomyopathy. Okay. This is normal. This is restrictive cardiomyopathy. So this is about the cardiomyopathy, main causes of cardiomyopathy, and how are you going to treat this. So almost we have completed CVS. This is for just for further reading the named murmurs way and where it is seen. Named murmurs and some named pulse is also there. What are they asking about pulses paradoxes? They're asking seen in cardiac tamponade. How are you going to see there is decrease in SBP due to impaired heart failure? Okay, will be shared with you. Any doubts in this? Any doubts in CVS? Any part of this presentation that you want me to repeat? Any doubts? Yes, yes, Harika. Yes, you have raised hand. Any doubts? Any part of this presentation that you want me to repeat? Sir, can you please tell what topics we learned? Yes, okay. We have learned about basic concepts about CPR, hypertension. We have learned all the congenital heart diseases. Then infective, this rheumatic heart disease, MI, angina, valvular diseases we covered. CCF we covered, conduction disorders we covered, AFib, atrial flutter, all the blocks, cardiomyopathies, all these we covered. Most important. Yes, any more questions? Somebody asked why diastolic murmur? Why diastolic murmur? Okay. See, in mitral stenosis, what is happening? I think there's some space. Okay. This is left atrium and this is left ventricle. So the blood from atria to ventricle is unable to pass from left atria to left ventricle because of this stenotic valve. Okay. So normally, when should the blood pass? AV valve will remain open in atro, in wait, I'll write here. AV valve, semilunar valve. When will they remain open? When will they close? AV valve will remain open in diastole. Okay. Semilunar valve, they open in anybody. Semilunar valve in open in systole. Okay. So AV valve, so mitral valve is AV valve, no? So in diastole it should remain open, no? But it is not open. It is stenos valve, luminally narrow. That's why we have diastolic murmur. Okay. Now, having said that, we have a diastolic murmur. Having said that, whenever during atrial systole, whenever with forceful pressure, the atria, when it tries to push through this stenotic valve, that sound will come, but that is not murmur. That is known as opening snap. Okay, opening snap. Opening snap. Yes, Yogita, your doubt cleared. Diastolic murmur, opening snap. Okay. Yes, cleared, Yogita. Okay. That is opening snap, diastolic murmur. Okay. Any more questions? Yeah. Somebody asked review conduction disorders. It is okay. Baba, listen. Conduction disorders में basically SA node to conduction AV node. From AV node, it should reach the further one like bundle of his Purkinje fibers, ventricular musculature. ठीक है? Bundle of his Purkinje fibers, ventricular musculature. Now, mostly conduction disorder में this pathway will be affected. Okay, this pathway. So now, if conduction, here conduction, there will be a block in conduction. So if block is like delayed block, the conduction should go in 0.1 second, but it is not going. It is going after 0.3 seconds. So we say it is delayed. Or the block is intermittent, meaning sometimes it occur, sometime it will not occur. Or the block is there and there is no conduction at all. Okay. So delayed conduction, intermittent conduction, and no conduction. So if it is a delayed conduction, we say it is first degree AV block. If it is intermittently conducting, it is second degree AV block. If it is not conducting at all, meaning impulses will come and they still, they will not go beyond this AV node. Impulses from SC node comes and not go beyond this AV node. So we say it is third degree block. Okay. Third degree block. That is what we are expecting to find. See, delayed conduction means in ECG, what is this conduction? What are we trying to show? PR interval. So PR interval will be more here. So in intermittently conducting means what? So it is of two types now. Second degree is of two types. See, type 1 is there, second degree type 1. So I'll write 2.1 and second degree type 2. See, 2.1 name, what are you expecting to see? So in all second degree, there is an intermittent conduction. But 2.1, in second degree 2.1, PR interval is progressively enlarged. Meaning, for example, now PR interval is 0.1 second. So in the next heartbeat, PR interval will be 0.12. Next heartbeat, PR interval will be 0.14. Now 0.16. So the progressive enlargement of PR interval will occur until there is only P will be there. There will be no QRS complex. Meaning what? Ventricles will not contract. So this indicates AV block. Okay. So this is 2.1. In 2.2, what happens? PR interval will be more only. For example, PR interval, let's say normal is 0.12 to 0.12 to 0.21. Normal PR interval is 0.12 to 0.21. This is normal PR interval. Okay. But so enlarged, PR interval will be enlarged. Let's say it became 0.25. So in next beat also it will be 0.25. In next beat also it will be 0.25. But in one beat there will be no QRS complex. Only P will be there, but no QRS complex. This is sudden drop of QRS complex. This is 2.2. In third degree, what are you expecting to find? Only P wave will be there. Only P wave. P wave indicate atrial contraction. But after some time, ventricles also has to contract, no? So ventricles contract separately. Okay. So P wave will be separate, QRS complex will be separate. So having said all this, I will show you now ECG so that you will better understand what I am telling. Okay. Where is that ECG? See. First degree, what did I tell? Delayed conduction. Meaning, see, PR interval is progressively enlarged. Normally, PR interval, how much gap should be there? Less than 3 boxes. Okay, so this is the 3 boxes. But here you see, this is P wave and this is the R wave. How much gap is there? More gap. Okay. Now here also, PR interval is more. PR interval is more. First degree is delayed conduction. Now second degree you see, second degree में 2.1. 2.1 मतलब first second degree type 1 में you see progressively PR interval is enlarged. Progressively, this is P. Where is it? Okay, so this is P, and this is R. This is R. Okay, so P, R. So progressively PR interval is enlarged until only P wave came, but no QRS complex came. Meaning what? Here block happened. This is second degree block. Now third degree block, second degree type 2 may you see. Type 2 may there is fixed PR interval. Since beginning there is fixed PR interval, but after 1P there is no QRS complex. Okay. So this intermittent conduction problem is second degree. So it can be type 1 or type 2 depending on that. Now third degree may you see P waves occurring separately, Q wave, QRS complex occurs separately. This indicates atria and ventricles are beating separately. Okay? You understood, Zubair? Any more doubts? Any part of okay? Why AV blocks happen? See, all these fibrosis that we have to write. Main cause is fibrosis. Chronic trauma, fibrosis. Like recurrent MI में अगर fibrosis होते गया ischemic heart disease, potassium disturbances, hyperkalemia to be precise, and the some of the drugs. They are the main causative agents of AV blocks. AV blocks. Okay. 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 I'll stop here. Thank you, everyone. Thank you for your time.